Dr. Safa, I'm recording from the start. Needle stick injury. There are two scenarios for needle stick. Number one is the nurse, and number two is the child. Okay, let's speak simply. In the needle stick injury, this is a sort of worried patient because the nurse is very worried and the carer of the child is also worried in the two scenarios. So what you can do, you can reassure and say, I'm going to address all your concerns, so please bear with me. Okay, now you will ask some question. In the needle stick injury, let's start with the nurse. You will ask the nurse, when did this happen? And how did this happen? And regarding the prick or regarding the stick, was it superficial or deep? So was it superficial or the selected questions are, was it superficial or deep? Then ask about the size of the needle, wide gauge or narrow? Wide gauge or narrow? Okay, was it contaminated with blood? And what did you do after that? She will tell you, I washed with water and soap. So again, the depth of the wound or the depth of the prick. And after that, you will ask her about the needle itself. You will ask her if she was gloved or not as well. Number 3. Number 4, you will ask her about was there any blood drops over the needle or not. She will tell you, doctor, I was taking a sample from my patient. And what did you do after that? I washed it with water and soap. Now you elaborated the incident itself. Ask about the patient. What's wrong with the patient? She will tell you, doctor, he was suspected to have meningitis. How old was he? And was he conscious or not? So the state or the case of the patient, the age of the patient, and the consciousness of the patient. Why these things differ? Because the age of the patient, you know, if the patient is older, the chances of hepatitis are higher. And as well, if the patient is conscious or not, or the patient is conscious, you can take his consent to do HIV test, or you can simply ask him about his HIV states. But if the patient is unconscious, this means that you need to wait till he regains consciousness. Okay, so now she will tell you that the patient was 18 years old, suspected to have meningitis, and he was unconscious. Okay, now your history is done. Move to the concern. May I know what's your concern directly? I will tell you the concern and how to answer it. So please write after this, just write 2 or 3 points after each concern. I need you to do this. For the concern number 1, she is concerned about meningitis. You would simply tell her that the meningitis is not blood-borne infection. But tell me, were you taking all universal precautions? Were you wearing gown and mask? She will tell you, yes, doctor, I was wearing them. Okay, this is good. This means that the chances are very low in your case. So she was taking universal precautions. However, we will take a sample from you and send it for the microbiology to seek any microbiological advice to give you prophylactic antibiotics. So you will take sample from her and seek microbiology advice for prophylactic antibiotics. This is the point. Number 2, regarding she can bring or she cannot bring the concern about the AIDS, HIV. She's concerned about the HIV. Regarding the HIV, if she asks you about the HIV, you would reply as the following. How to reply about the HIV? Number 1, she was wearing gloves and the prick was superficial and she washed her hand with water and soap. This is regarding the prick. Number 2, the chance of transmission of HIV is 0.3%. So chances of HIV transmission through such kind of needle sticks is 0.3%. Number 4, the patient should be the patient should be HIV positive in the first place. You can give stats or not. I told you the chance is 0.3%. I mean, you definitely, when you are explaining to the nurse, you can sometimes forget some reasons from what I say. Okay? But I'm telling you the full thing. So number 3, the patient needs to be HIV positive in the first place to transmit HIV. She will tell you, doctor, but we don't know if he's HIV positive or not. At this point, you will simply tell her that we can ask, as the patient is unconscious, this means that we cannot ask him, and we cannot also take a test from him. However, we can ask his family if they know about his HIV status, or we can check his medical records. Or ultimately, we can wait till he wakes up so that we know we can ask him testing for HIV. Doctor, but what can we do meanwhile? Now you will offer here the post-exposure prophylaxis. Post-exposure prophylaxis, 2 drugs taken for 28 days after the prick itself. So she will take them for 28 days. The golden time to start is within 1 hour to 72 hours. I mean, it can be taken up to 72 hours after the stick, the needle stick. Okay, these medications sometimes can be having some side effect like tummy pain, vomiting, and some liver problem as well. So it's advisable that we test you after starting them. So what to do here is that you will start the post-exposure prophylaxis right away. This is number 1. Number 2, you will take a sample from her for microbiological record. So we will take a sample from her to show that she was not HIV infected before the stick. Okay? Why you take a sample? Because usually the HIV is prominent in the blood after a few days. I mean the antigen itself. So if she takes a sample right now and sends it to the lab, and the sample is free, and after a few days it becomes positive, this means that definitely the reason of the needle stick is, or the reason of HIV is the needle stick. So this was occupational injury, and she can use it medically later. Number 3, you would offer her some support. You can refer her to the occupational department. They can offer her some counseling sessions to support her, because this can be traumatic or traumatizing to some people, especially the medical people who had needle stick. This can lead to PTSD in some people. Some people can even quit surgery because of this. Okay, so what are the warning signs? The warning signs is that she should not donate blood. She should practice safe sex. And if she is willing to become pregnant, come back to us. So warning signs are: number 1, practice safe sex. Number 2, do not donate blood. Number 3, if she is willing to become pregnant, come back to us. Then she's having some other concern regarding the HIV, the HBV, sorry. What about the HBV here? The HBV will assure her that the chance of transmitting the HBV is quite low. Still, this is 0.3%. So the HBV is 0.3% as the HIV exactly. And again, you wear gloves. The prick was superficial. You wash your hands with soap and water. One more thing we forgot about the HIV. The HIV as well, you can test her for the HIV after 3 and 6 months from now. So you will test her for HIV in 3 and 6 months from now. You cannot test her right now. You will test her in 3 and 6 months. The HIV. And regarding the HBV as well, what you are going to do, you are going to reassure her the same way you reassured about the HIV, but you need to ask her about her vaccination status. Have you ever received HBV or HBS antibody vaccine before, or have you received the vaccine of HBV before? She will tell you yes. How many doses? I received 3. Any booster doses? Yes. When was the last dose? She would tell you last year. Okay, for the HPV, you reassured her. You asked about her vaccination status, number 2. Number 3, you will offer her something. You will tell her that we can give you jab right now, or the vaccine right now. We can give it to you right now, the vaccine itself, the booster vaccine or the booster dose of the vaccine. And after it, we can test your liver function. Okay? Liver function test can be done now and in 3 and 6 months. Now and in 3 and in 6 months. But we can test your HPV antibodies in 3 and 6 months from now. So again, to sum it up, the HIV can be tested in 3 and 6 months from now. While the HPV, in the HPV, the antibodies themselves, they can be tested in 3 and 6 months from now. But the liver function test can be tested now and in 3 and in 6 months. Okay, warning signs should be if you develop any yellow discoloration of your eye or any tummy pain or any change in your wee and poo, come back to us. Okay, last concern is that she can be worried about the wound infection. You will reassure her that this was just a superficial prick, small prick, and your wound is clean. Okay, so in case just you developed any swelling or redness or any discharge from your wound site, come back to us because we may need to give you antibiotics. Now, the end of the station is that if she told you that she just washed her hand with water and soap, you would warn her that number 1, have you informed or have you told anyone to resume the procedure? I mean to continue the blood sampling. Number 2, have you discarded the needle in the sharps bin? Number 3, have you informed our senior and filled instant form? Number 4, inform the occupational health department. So again, what are the procedures after any needle stick injury? Number 1, ask someone to resume the procedure. Number 2, throw the needle in the sharps bin itself. The needle which pricked you, throw it in the sharps bin. This is number 2. Number 3, inform senior and fill instant form. Number 4, inform the occupational health department. You can use it in the history taken. For example, when you ask her about the prick, you'll ask her when was it, how was it superficial or deep prick? What about the needle? Wide or narrow gauge? Was there any blood on it? Were you gloved or not? And then what did you do after that? I washed my hands with water and soap. And did you discard the needle? Did you ask someone to follow or to resume or to continue the procedure? You can ask them in the beginning, or you can just let them be in the end and ask her again. Did you ask someone to continue the procedure? Did you throw it or discard the needle in sharps bin? Number 2. Number 3, have you informed senior and filled instant form? Number 4, which is very important, inform the occupational health department. This is the nurse. The nurse is very worried. You have to reassure her from the beginning that you are here to talk to her and address her concern. And we are going to sort it out for you. Please don't worry. Okay. Second thing is the same station, needle stick injury, but with a child. Carla. This Carla child, she has been playing in the park and she had a needle prick or a needle stick. Now her carer, she is very worried about her. That's why she brought her here. And she is worried because actually she thinks that she is careless. And her mother, the mother of Carla, will punish her. That's why the carer is worried. So the babysitter is really worried and she was the one only who's going to talk to you. Carla is not in the cubicle. So you will go and talk to her. Doctor, I'm really worried. Little Carla, doctor, she was in the park, she was playing, and she had a prick in her finger. So now reassure her again. Ask about the incident itself. Like, when was that? How was it? Was the needle superficial, or was the prick superficial or deep? What about the needle? Was it narrow gauge or wide? Very important thing here to add, or very important question: was it attached to a syringe or not? And was there any blood on it or not? Why this question about the syringe? Actually, because this needle was outside the hospital. So you have to ask this question: was it attached to a syringe or not? Okay, was there any blood over it or not? After that, you will ask her: was it trusty? Was it trusty? Because of tetanus. But of course, you will not here ask about was it gloved, were you gloved or not? And did you scar it in sharp pen or not? You will not ask here. You will just ask these two questions about the rusty and was it attached to a syringe. And what did you do after that? She would tell you that one of our neighbors, she took her to the bathroom and she washed her hands with water and soap. Well done, you did the right thing. So now you can take some history from her. Like, for example, how is her general health? Does she have any medical condition? Does she receive any medications or take any medications? Any allergy? Any family history of any problem? How about her birth? Is she up to date with jabs? Are you happy with her read book? Usually, the babysitter does not know much about Carla because she is not the one who knows about her medical condition. She was just recently hired. So reassure her that don't worry, please. We will talk to her mother as soon as she comes here. Because actually, she will tell you that her mother, I called her mother as well, and her mother is coming in a while. Okay, now move to the concern. May I know what's bothering you? She is worried about the nasty infection that come after needle prick. What are the nasty infections? This is the tetanus, basically. Let's speak about the tetanus number one. Tetanus, actually, you will tell her that in this point, actually, we give the children tetanus jab. Tetanus jab is given in 0, 4, and 8 months. Sorry, it's given at 2, 3, 4 months age. 2, 3, 4 months age. And after that, it's given at the age of school. So 2, 3, 4 months, and after that, it's given at the age of school, the school age. Carla is 5 years old. So you would ask her, has she received her booster dose, which is a school dose? She would tell you, I don't know. Even if she did receive it. What you're going to do right now, you are going to give her immunoglobulin, tetanus immunoglobulin, and booster tetanus vaccine. So here in this case, you are going to give tetanus immunoglobulin, which work faster against tetanus itself, and tetanus vaccine or tetanus jab. Okay, so this is what you are going to give for that tetanus. Number 2, regarding the HBV. HBV itself, the chances of catching HBV are low as well. The same thing, chance of catching HBV is low, the prick was superficial, and you have washed your hands with water and soap after that. Okay, but for this case, actually, we can give her hepatitis jab. You can give her booster dose of hepatitis jab. Okay, this is regarding the HBV. And definitely we can test her liver functions, and her hepatitis. The liver function can be tested in 0 and 3 and 6. 0 and 4 and 8. Those are the liver function, and as well the serology or the antibodies can be tested in 0 and 4 in 4 and 8 months from now. So 0, 4, 8, and here now 4, 8 months. Regarding the HIV as well, it is very similar. But the thing is that you can reassure her. Here in this case, we do not give post-exposure prophylaxis. In children, we do not give post-exposure prophylaxis, especially here the incident or the prick was outside the hospital. So if the prick is outside the hospital, the chances of catching HIV are very low, especially if it was superficial and she washed with, the hands with water and soap. But what we can do, we can simply do HIV tests for her after 3 and 6 months from now. So in 3 and 6 months from now, we're going to do HIV testing. Last thing, if she's worried about wound infection, you will tell her the same thing again. The prick was superficial. However, if she develops any redness or swelling or discharge at her wound site, please bring her back. We need to take a sample from the wound and give her antibiotics. One important thing not to forget here is that there are only 3 concerns or 4 concerns. Number 1, tetanus, the main concern. You will give tetanus, immunoglobulin, and vaccine. Why both things? Because the immunoglobulin works faster, and the vaccine is just a booster dose to her previous vaccinations. And number 2, she's worried about HIV, and she's worried also about HPV as well. Last thing is wound infection. No need to do further procedures here like informing senior and such things because this is like something outside the hospital. And one important thing as well, after finishing taking history, like after the past medical history and the birth questions, you need to ask to examine Carla wound. You need to tell her, I need to have a look at Carla wound. The examiner at this point will give you a photo of the wound. The wound is very clear. It doesn't have any problem. Just simple wound. Why he is giving you a photo? To show you that there is no contamination and as well there is no wound infection. So do not forget to examine the wound as well. Okay? So, has anyone got any questions here so far?
Brother.
Hello? Hello?
Brother,
Yeah?
we need to mention about the conditions on our own, or the patient will ask on their own.
Excuse me, Masi, there is a noise around you. Again?
We need to ask about the conditions on our own after one by one, or the patient is going to ask the conditions on their own,
Well,
like step by step.
sometimes she tells you only, I'm worried about nasty infections. So at this point, you will speak about tetanus first, and after tetanus, you will speak about HIV and HPV, even if she did not ask about them. I mean, here in this station, you have to, even if the care or the babysitter, if she herself did not ask you about all the concerns, you still have to bring them on all. And the concerns are usually tetanus here, and HPV and HIV, and after that, the wound infection. The consent taken for a child, actually what you're going to do to reside, I told you in the beginning that you will reassure her and you will tell her that when her mother comes, we're going to have a talk to her about everything. And by the way, if she is still confused about her vaccination status, because I told you the carer or the babysitter, she doesn't know much about her vaccination and about her health. So what are you going to tell her that, especially when it comes to the tetanus, that definitely you are going to discuss her vaccination status with her mother when she comes. However, we may need to give her tetanus immunoglobulin and tetanus vaccine as well.
Dr.
Yeah.
I was giving a little tip on this station. It would be a sort of nice idea to say the carer that it would be a good idea to ask from the parents if, to have a little binder for you.
Little?
With all the information. Binder with information, medical information on a child and emergency numbers for the child's pediatrician and, you know, the basic information. Then she will have it with her.
Yeah, that's good. That's good. I mean,
yeah, sort of little touches, sort of interpersonal skills. I mean,
yeah, that's a good idea.
There's
I mean,
no
because
need to say though.
Yeah, no, actually, this is good because she's a babysitter and she can be exposed to such situations later.
Yeah.
Yeah.
Yes, and she will have a full information with her, and she will be more equipped and less worried.
Yeah, that's true.
I mean, you get the simulator on your side. She will like you more.
Yeah, exactly. This is very good. Seriously, this is a very good point. And
It's just
huh?
it's not necessary. But if someone, I
No,
will
that's
say.
good. That's good because in this station you can finish it like in 6 minutes. So you still have plenty of time. Why don't you offer her some good solutions and some good like reassurance, because she's really worried. She's worried that she lose her job, or her mother was the mother of Carla was called her. Dr. Safa and Dr. Zaid, what will happen is that you are going simply to tell her, we are just talking to you right now and reassuring you, and we will have definitely a talk with her mother after she comes, after the girl or after the mother comes, because the mother is on her own way right now. So we are going to talk to the mother, and you will have a talk to her about Carla and her vaccination status and everything. I told you that you will say this in the beginning of the station. Dr. Ofudeli, do we ask if she has the needle with her? I didn't ask this. I mean, I didn't see this question anywhere, but you can ask it. But who will keep the needle with them? This is what I wonder. I mean, usually they discard the needle and sharp spin. If she asks about virus C or HCV, simply again, but the chances of catching HCV is 0.03, not 0.3%, no, 0.03%, which is even lower. And for the HCV, there is no vaccination. You just ask for liver function tests in 0 4 8 months. And you can check the virus status, the virus antibody in 4 and 8 months. Okay, you can ask her what she did or what she did after that. She will tell you, doctor, I threw the needle and I washed her hands with water and soap. This is what we can do. And by the way, I told you that you can ask her in the middle about the needle itself. Is it wide gauge or narrow? I mean, when you ask her, because basically this question is for to explore these three things. This question, I mean, you are asking this question, what did you do for the needle? Why I need the needle? Because I need to see if it is wide gauge or narrow, and to see if it was rusty or not, and to see if it was attached to a steering or not. So if I ask these three questions in my history, this means that I covered the thing about the needle. Yes, you know what? Everyone knows that, for example, wide or narrow needle. It's very obvious to anyone. And usually they do not bring the needle with them in the station. They do not bring them because they are already contaminated and they are worried from them. So what I think is that she will tell you, I washed her hands and I threw it in the rubbish or in whatever, on sharp spin or whatever. She will tell you like this. So that's why you will ask her this question from the beginning to save yourself time. Like about the needle.
Dr.
Yeah.
Hello, Dr. Hamid.
Yeah.
Actually, in this station, we have to cover three things. First of all, tetanus, hepatitis B virus, and HIV virus. So,
Yeah.
should I follow my chronology or should I ask the Carlos?
Definitely. This is counseling station, Dr. Zaid. Dr. Mahdi. Dr. Mahdi, in any counseling station, you ask the patient concern first.
Okay. Should I approach that? There is three things can be happened. So, what should I discuss first?
Usually, I will tell you something. Usually, even the nurse herself, she brought the meningitis first. Why? Because this is the most acute thing. And here in the child, the most acute thing is the tetanus. You know, the HIV
Yes.
and the HPV, they can take years to develop. But the tetanus can kill her in a few hours. Okay? That's why she is worried about that. That's why she brings tetanus first. And even if she did not bring it first, you have to bring it first. I told you, you have to start from tetanus, and after that you can bring the other things like HPV and HIV. And similar in the nurse, you usually should start with meningitis.
Okay.
Though it is
Actually,
not a blood.
I had these stations. I finished maybe within 5 to 6 minutes.
Yeah, I
after
told
I
you.
passed.
Yeah.
Actually, I am the first. I thought after taking these stations, I thought actually I have. Did I miss anything? Actually, I was thinking just in the stations, sitting in the stations. But Alhamdulillah, I passed. Maybe there is very small stations, very small.
Yeah, this is one of the
largest
nicest stations. This is one of the nicest and the smallest and shortest stations as well.
Yes.
And
Yes.
did you ask her the same questions that I told you?
Exactly one or two. Maybe I didn't ask about the attached with needle or not. And yes, I asked everything. I got 7 or 8 maybe in these stations.
Okay, good. Interpersonals, what about it?
2.
Oh.
Only 2.
If you were a little bit,
yeah,
if you were a little bit more reassuring, Mahdi, if you were a little bit more reassuring, I would say you get 10 in this station, or even 11. It's a very easy station to get 10 or 10 to 12.
Hello.
Yeah.
Dr. Mahdi is very rude in terms of speaking.
Don't say this. Don't say this about your husband. You have to encourage him right now, not discourage him. The guy is having his exam like in 1 month.
Yes, I am.
Yes, I know. Actually, I personally, I am a little bit lack of emotion, and you know, I am good, and by look, I am very good. I know, but I have to change myself. I don't know.
No,
Is he her husband?
Hello?
Yeah.
Yes, I am.
Because I can say that only to my husband. I can't say it to someone else. Unless I'm good.
Yes,
Okay.
you're right.
I don't like this conversation to be carried on. Just go to next station, please.
Yeah, this is also rude, okay?
Okay.
Maria, family issues aside, okay?
Okay, no problem.
No, what I wanted to tell you, Dr. Mahdi, in any counseling station, Dr. Mahdi, seriously, in any counseling station, if you are reassuring and if you are nice, you know what? Even if you did not finish the station, at least you will go out with 4 interpersonals and 2 data gathering and 2 management. I'm telling you the least score that you can reach. The counseling stations, Dr. Mahdi, are the core. The core in the counseling stations is your interpersonals.
Okay. Okay, I will be very much sweet next time.
Yeah, I hope so. Okay. I hope so, really. I hope so, because you have no other option. And okay, so this is a station. I think this is one of the easiest. By the way, guys, when do you bring them, these stations in one day, these stations are, because you are just about reassurance, those 2 stations, no knowledge. You don't need to know anything. Okay, let's discuss some of the challenging stations for today. Like what? We're going to start with the warfarin. I know this station is one of the most favorite for some people. Not favorite, it is a nightmare actually to some people. Let's simplify the warfarin stations for now. The warfarin in the warfarin station, you know, usually the guy is having a learning disability. In any learning disability, you have to follow some rules. What are the rules? The rules are, number 1, you have to be very, very, very simple. Some words cannot be said. Like what? Don't say the word medication. Don't say the word frequency. Don't say the word side effects. Don't say the word drug interaction. Don't say the word blood clot. And definitely don't say the word DVT. Okay? So do not use any medical jargon. In any station, if you use any medical jargon, sometimes it can pass. The simulator can pass it. But in this station, if you use one medical jargon, believe me, the simulator will ask you, what? Even if a single word, you should not use it. He's having a learning disability. So the general approach to this station is that, number 1, you have to ask his reason for visit. Number 2, assess the idea. Do you know about your condition? He is coming usually for a DVT review. Okay. So he will tell you, I'm here for my review. Okay, this is number 2. So assess the idea about the condition. So number 1, reason for visit. Number 2, idea about condition and how the condition is managed. Number 3, again, this is drug counseling. I told you. The drug counseling we speak about, number 1, the drug itself. Number 2, some other things, like some other triggers, like the epilepsy. So regarding the drug, we speak about, number 1, the frequency and the compliance. Number 2, side effects. Number 3, drug interactions. Okay, this is regarding the drug. Number 2, I mean, apart from the drug, we finished the drug right now. Here, there is no triggers. Unlike the epilepsy. Epilepsy, we had to speak about triggers. But here we have to speak about something we call anti-coagulation folder. What is the anticoagulation folder? It's number 1, alert card. Number 2, record book. And number 3, leaflet containing the warfarin information. Again, alert card, record book, and warfarin leaflet. In the end, you can tell him, do you have any family member with you? Whom do you live with? He will tell you, I live alone. Don't you have anyone by your side to explain this to him or her? He would tell you, for example, his sister visits him from time to time. So now you have to make sure that you can explain to the sister or to the nearby family member, because this guy is having learning disability. He can forget about everything at any time. And you can also warn him in the end. If you forget anything, you can refer to the leaflet that we are giving you. And you can also call us at any time to inform. Okay? So after finishing that, you have to make sure, you have to double check that this patient is having someone by his side to explain to him, because he can likely forget anything. He's having learning disability. Let's speak about the station. Let's show you. So number 1, I assess the reason for visit. The reason of visit is that this guy is coming for his DVT review to do the Inr test and receive the Inr result. The task here will show you that his Inr is unstable. Do you have any idea why the Inr is stable, Dr. Muniba? Dr. Muniba?
Sorry, can you repeat the, yes, can you repeat the question?
Do you know from the task why the Inr is unstable?
Yes, because he's not taking the warfarin as prescribed.
And why he's not taking the warfarin as prescribed?
Because he has learning difficulty and he is taking the medicine on his own.
Exactly. So this guy is having learning difficulty. So what you can do here, Dr. Muniba, if someone is having learning difficulty and they may not, yeah, exactly, tell me.
What were you saying?
If someone is having learning difficulty and they are supposed to follow the drug, what are the safety netting here in this station that you can give in the end?
We can explain how to, like in a very polite and a very slow way, that how to take this medicine and when to take it. Just make sure that he is understanding whatever we are saying.
Perfect,
and,
perfect. But I need in the end, what will you warn about?
We can warn about if you have any headache, if you have any dizziness, any bleeding from anywhere.
Dr. Muniba, I'm likely to forget everything you say. I may forget everything you offer me right now because I'm having learning disability. What else you can offer me to overcome?
Ask about any close relative with whom we can talk about it.
Exactly.
Yeah, obviously family member.
Yes, exactly. This is safety netting. This is your, can you imagine, this is your safety netting here in this station? Because actually this guy is incompatible with the drug just because he forgets or he's not fully aware about it. Okay?
Okay. All right.
Okay, so now you can close your mic, Dr. Muniba.
Dr. Ahmed, please, can you say that again, please?
Okay, so you have to inform one of the family members in the end. I mean, in the end, you have to at least tell the patient, do you have anyone living by your side or living with you? Because we need to explain to one of their family members about this to make sure that he's not going to ignore the medication again, or he's not going to forget the medication again. This guy is having learning disability. So he may not, I mean, after this consultation, he may forget everything you said, or he may not be even concentrating sometimes. I will tell you the solution during the station, Dr. Islam. I will tell you about everything. But in the end, are you sure that you remember everything? No. And that's why I need to inform one of the family members at least. You can mute yourself right now, Dr. Yemi. The thing is that here, in this station, simply, guys, you are to record his conversation. I'm not sure if he's having mobile or not right now. Anyway, I will tell you the solutions. Actually, it's very simple, but you just follow it. So number one, I assess the reason for visit. He's coming here for his review. Which review? He will tell you, doctor, I'm coming for his review because I'm having some pain in my leg. Do you know, for example, I'm so sorry for that. Are you comfortable right now? Yes, doctor, I can manage. Well, that's great. Tell me, do you know why did you have this pain? So now you are assessing the idea about the condition. Do you know how you have or why you have this pain? He will tell you, yes, doctor, because I think I'm having something in my legs, like some jelly in my legs. He basically speaks about the blood clot. So you will tell him, actually, you're right. You're having this pain because of something we call blood clot, which is something like stiffness or over stiffness of the blood in your legs, which form a jelly or a plug-like formation in your blood vessel or the tube supplying your leg. So again, the blood becomes as thick as a jelly, and that's why it forms a plug in your leg or in the tube containing blood in your leg, and that's why the blood will not reach your legs properly. And that's why you are having this leg pain. Okay, doctor, that's right. So for that, actually, what did he give you, or how have you been given anything? He will tell you, yes, doctor, I was given warfarin, or I was given these tablets, and he will show you warfarin. Excuse from the patient and tell him, okay, I'm going to have a look at it. You will find warfarin 5 milligram. So now what you are going to do, you are going to ask him, have you taken it regularly as prescribed? He will tell you, no, doctor. May I know why? Doctor, I just didn't take it. I lost track. I was taking it only when I was having leg pain. And this is what you have been told. He will tell you, doctor, they could have told me. I think they told me, but I lost track. I'm not sure. So he's taking the medication irregular. He's just taking it whenever he's having this leg pain. Remember, like the guy of epilepsy. Okay. So now I assessed about his condition and his management. Now I know that this guy is not taking warfarin regularly. So I need to ask him regarding the relevant condition. For example, when someone is not taking warfarin regularly, likely the leg pain may recur. So I will ask him, do you still have the leg pain? Doctor, actually, yes, I get it from time to time. What about any heart racing or any problem like any chest pain? No, doctor. So this guy is having leg pain definitely because he's not taking warfarin regularly. Okay, now you explain the medication to him. Okay, I told you, let's start explaining the medication. Actually, you are having this leg pain because you are not taking the medication or you are not taking the pill regularly. Doctor, I thought I should have taken it just only when I'm having pain. You would tell him you should take it like once daily at the same time. Doctor, but I may forget taking it. Okay, that's fine. You can set an alarm at 6 p.m. every day. Doctor, but what if I forget? Can I call you to know when to take it and how to take it? Yes, definitely you can talk to me and call me. We can provide you with a leaflet as well to show you the instructions to take it. Okay, doctor. He is still bothered, right? At this point, actually, you have to check his mental capacity. When you are speaking about the drug, this guy is definitely could be lacking mental capacity. So you have to check him. Do you know why we give you this pill? Why, doctor? Because this pill actually is a blood thinner. It will prevent this plug from forming in your leg. And do you know what will happen if we don't give it to you? No, doctor. The plug will return again, will recur again, and it will give you bad leg pain. And we don't want this to happen to you. Yes, doctor, I don't want this to. Okay, neither do I, neither do we. And that's why we're giving you this pill regularly. So part of your drug here is to check the mental capacity. You can check it after. exactly in the beginning of speaking about the drug. For example, do you know why we are giving you warfarin and what will happen if we don't give it to you? And after that, you can speak about the drug. We need to give it regularly at the same time every day. And after speaking about the compliance, now you need to speak about side effects. Don't say side effects. Actually, you will tell him that this drug has got some side effects like unpleasant effects. Say unpleasant effects. What are they, doctor? Actually, sometimes it can cause, maybe you can say like some tummy pain, like some nausea and vomiting, but the most prominent side effect or the unpleasant effect is bleeding. So have you experienced any bleeding from anywhere in your body? Any nose bleeding, any blood in your stool or in your poo? What did you know? So now you have to warn him about side effects. Like, for example, if you experience any severe bleeding, like for example, unstoppable bleeding from your nose, or if you experience any severe headache, or if you're involved in any accident, please come back to us. Doctor, but what if I just break my finger? Definitely, in this case, you have to press over it, like put a sterile cotton or a sterile cotton and press firmly over it for 5 minutes. Okay, doctor. And don't worry, please. We're going to monitor your INR, which is how long it takes your blood to be thick. Sorry, how long it takes your blood to be thin. We are going to monitor it to you regularly to see or to check about your blood to prevent this bleeding from happening to you. So regarding side effect, you will tell him about if he develops severe headache or accident or unstoppable bleeding, come back to us to the A&E. And we will also be monitoring you. The INR, which how long it takes your blood to thin. So this is second compartment. Number one, we spoke about the compliance of the treatment. Number two, we spoke about side effects. Number three, speak about the drug interaction. You will ask him that you should not take any pill except after seeking medical advice, because some pills can can interfere with the action of this pill, especially the painkillers. This is number one in the drug interaction. Number two, so he will tell you, doctor, I can't wait. I need to finish this meeting today to go to the pub and take much alcohol. I'm really excited to watch today derby or watch today match or something. You would tell him, well, I'm glad that you're happy, but I'm afraid that binge drinking or drinking much alcohol can interfere with the action of this pill as well. So please make sure that you drink only in moderation. And it's even advisable to cut down alcohol here, because the alcohol can interfere with the drug. Okay, number three, about the diet. May I know what do you prefer in your food? Don't say diet. What do you prefer? I mean, do you have any preference for your food or your meals? He will tell you, yes, I eat everything. I eat, for example, he can eat sometimes he can eat some cranberry, or he can drink some cranberry. He can drink some blackberry, or eat some blackberry or something. You will advise him not to drink too much cranberry juice, because this can interfere with the warfarin as well. So simply, if you are confused, you can tell him, do not make big changes in your diet, because major changes in your diet can interfere with the action of your warfarin or your pill as well. So number one, the other drugs. Number two, the alcohol. And number three, the diet changes. If he ever asks you for how long should I take it, you would tell him that usually we keep monitoring you to see how long it will take you to take it. But usually we give it to our patients for 6 months. 6 months, of course. Now you finished the drug. Now speak about the anticoagulation folder. We will provide you with some. Now you will find the anticoagulation folder on the table by your side. You will pick it, excuse yourself from the patient, and pick it up and tell him, okay, this is alert card. The alert card is a card in which is written your warfarin dose and details of your INR clinic and the readings of your INR or the last INR and the address of your INR or anticoagulation clinic So all the details, you'll find all the details written in the alert card before your eyes. So you tell him that he needs to keep this alert card with him everywhere he goes, especially to any healthcare office or healthcare place. And he needs to offer it to any medical health professional because it shows that he is taking warfarin. This is regarding the alert card. Number 2, record book. He should take the record book, or he should bring the record book here when he's coming here, because this book will write the INR reading in it. Doctor, should I write the INR reading myself? No, actually we will be writing it for you. So this is the record book. And we will offer you a leaflet, as I told you, to contain all the information about the warfarin. Okay, doctor. Safety netting here. In safety netting, you have to tell him, may I know whom you live with? Do you have, or do you need us to explain it to anyone else? Okay, would you like us to give a call and or to have a meeting with your sister, for example, to explain it to her? She can help you with that. Okay, one important point here. If he tells you that he forgets taking the pill, or he may forget taking it regularly, you can offer an alarm to remind him. Or you can simply ask him a very simple question. Do you watch TV? Do you watch any series or movie? For example, around this time, like around 6 p.m. What about taking it together with your series? Anything you can offer him, any solutions that comes into your mind to comply with it. One other important point, sometimes, and not sometimes, most of the times he'll keep interrupting you in the middle. He'll ask you, doctor, where is Jill? Your nurse colleague, doctor, she used to take the INR or the test result from me. So you will tell him that Jill is in another room, she's seeing other patients, and definitely I will ask her to come and see you after we finish this chat, or after we finish our talk. So reassure him that Jill is busy at the moment with other patients, and definitely she will come to see you after we are done. He may keep interrupting you like this more than 2 or 3 times. So you have to be quite reassuring. This is one scenario for the warfarin. What is the other scenario for the warfarin? It is even simpler. The other guy is coming here because he was admitted here. Okay, so this guy is admitted here since long. And now he is discharged. So this is the first discharge after prescribing warfarin, or after being prescribed warfarin. So this is different from the previous one in one thing. The previous one is coming for follow-up. I mean, this is not the first prescription of warfarin, but this guy is going to be discharged for the first time with warfarin. Very similar thing, very, very similar. But here is very important to talk to him about side effects in details. I mean, in the previous station, you may not have time to talk about side effects in details. But in this station, you have to mention about the side effects. Okay, let's see how it works. Again, number 1, reason for coming here. Number 2, understanding about his condition and how is he feeling right now. And what were you prescribed? He will tell you warfarin. Let's speak about the drug. Before speaking about the drug, I need to ask you a few questions which can be related to it. Like what? Now you can ask about side effects. Like what? Did you have any bleeding anywhere in your body? Do you have any medical problem? Any liver problem? Any blood disorder? Like this. Like ask 2 or 3 questions which can be related to the side effects of the warfarin. Like ask about any peptic ulcer, any liver problem, any stomach problem, which is a peptic ulcer, any liver problem, any kidney problem, any blood problem. You have to ask these questions before prescribing or before talking about the medication. Now we talk about the medications the same way as before. Do you know why we prescribe this medication to you? Now, you will not speak about the complications here. Why you will not speak about the complications? Because this guy doesn't have any problem with the warfarin right now. He's just starting to take warfarin. So you can speak about, do you know why we prescribe this medication to you? You will tell him, he will tell you no. You will tell him this is a blood thinner, which makes your blood thin to not form the plug again. Okay, doctor. Now we speak about the compliance of the treatment, how he has to take it every day at the same time. This is number one. Number two, you have to tell him actually about side effects as well, that he can start developing some side effects like what? Some headache, something, some like bleeding, some headache, some nausea and vomiting, some tummy pain. However, if he develops any severe headache or any other things, he can come back to us to the A&E. Wait for a minute, guys. Hello. So the thing is that we stopped at side effects. I told you that you have to warn him about side effects, like in terms of you develop any severe headache, or if you are involved in any accident, and if you are involved in any fall or anything, come back to us, to the A&E. And now we have to speak also about the drug interaction, the alcohol, and the diet. Okay, Dr. Muniba, take your time. And you have to speak about the alcohol and the diet and the drug interaction. And after that, you have to speak about the anti-coagulation folder. Same station, very similar to it. But the only thing is that in this case, you do not check his compliance because he did not already start the treatment.
Brother, what would be the safety rating here?
Safety rating here is the same. Family member, because he's still having, as well, this guy is having learning disability as well. Okay.
This guy also is having learning disability.
Yeah. This guy is having learning disability. This is not as frequent as the other one. I mean, it doesn't come too much as the other one. This is the old version. The newer version, not for the old pattern, no. This is the old version, like this is how it used to come before. But in the past 1 year, the other one, which is the other one, which is the follow-up, the one which comes. Okay, so you have to know both. In this case, or in both cases, actually similar approach. But in this case, you do not ask about, or you do not check his compliance, because actually this is the first prescription. No need to check the compliance. And here you have to warn him more about side effects. But the other one, I'm sure that he was warned about side effects before. Okay. 2 more stations about warfarin. I have to ask one question to anyone, and no, I will not ask to anyone. I will just speak to people. I need to see how people are concentrating today. Dr. Islam, tell me. Dr. Islam. Dr. Islam, open your mic.
Can you hear me?
Yeah, I can hear you right now.
Hello, doctor.
Hello, Dr. Islam. Tell me, Dr. Islam, by the way, if someone is having blood in the urine, hematuria, and this person INR is normal, and this person is taking warfarin, so what could be the cause of the hematuria? Again, he's having hematuria, the INR is normal within the therapeutic range, and he is taking warfarin, he or she. So, what could be the reason of the hematuria? Think about it.
INR is normal?
Yeah, INR is normal, warfarin is taken, and he or she is having hematuria. What do you think?
Search for other causes of hematuria.
How?
We ask if there is any, if the hematuria is painless, if there is any pain.
Exactly. What else? By the way, she is not complaining. She is not complaining of any hematuria. It is just her test result. I mean, it is not prescribed by the patient.
Not as a symptom.
Yeah, it's not as a symptom. And please, pure English. Okay?
Okay.
So don't get used to that. The thing is that now she is not giving you any blood in the urine, but you found it in the blood sample, or in the urine sample, sorry, that she is having microscopic hematuria. You know what is microscopic hematuria, Dr. Islam?
Yeah.
What does this mean? Like this hematuria is invisible to her eyes.
Yeah.
So what could be the reason here? I mean, now the reason is basically could be warfarin, right? Could be okay, not right. I was just testing your concentration. It is not right. It's not warfarin. Why not warfarin? this is the trap in this station. No, not side effect, Dr. Maria. Here, actually, and not blood disorder. It's not necessarily blood disorder. This is microscopic hematuria, guys. Microscopic hematuria means that this simply could be urinary tract infection. Very simple. Could be some injury, little injury, minute injury. Could be dietary factors. Okay. Ultimately, we need to run further tests to find out the reason. Okay. So here, this station is about one thing. She's your FY2 working in GP. Yeah, exactly, Dr. Muniba. Those are the and cancer bladder as well. Dr. Maria, I will tell you why it's not side effect. And by the way, please concentrate because your turn is coming next, Dr. Maria. I didn't pick up on you anytime right now, but from now you will be picked up. Yes, exactly, Dr. Bina. That's right. So number one, the blood test here show, or the urine test show hematuria. Other blood tests are very normal. The hematuria, by the way, is microscopic. Microscopic means very minute hematuria. The blood tests are very normal. The INR is 2 to 3. What does it mean that the INR is within therapeutic range? Which means that it is within the normal range which has been decided to this patient. So if the INR dose is normal and everything is normal, why would the INR cause hematuria if its dose is normal? This is the thing. So here in this case, she's coming for a test result. You will tell her, I'm having my test result, and you keep asking her some questions. Why did you have this test? She will tell you, doctor, I was just checking on myself. It was just a regular checkup. Well, that's great. Do you have any symptoms right now? Which symptoms you are going to ask about Dr. Islam? Provided that she is having DVT, that's why she is receiving warfarin, and she is having hematuria in the test result. So what symptoms to ask about here?
As I told you, if there is any pain in this hematuria.
No, you do not say pain in hematuria right now. She doesn't know yet that she's having hematuria.
No.
Okay.
I ask about the symptoms of renal impairment, like swelling in your leg.
Okay, one thing.
Like fever.
Okay, UTI.
UTI.
Okay.
Any pain if there is any small stones.
Okay, this is good. So I need just only one or two or three questions only. Why? Because these are the questions for the hematuria which I picked up from the test result, right? Number two, I need to ask her some other specific sets of questions as well about her DVT. How is your DVT? For example, do you have any pain? Do you have any swelling in your legs from time to time? So two sets of questions. Number one, question for the hematuria. Number two, questions for the DVT itself. Number three, move to the PMH. In the PMH, you will ask about any medical condition, and now ask about the warfarin itself. Do you take it regularly as prescribed? Do you miss any dose, or do you take any extra dose? Why I ask about extra dose? Because any blood anywhere in the body is a side effect of extra warfarin, right? So I need to ask any extra dose. Did you experience any side effects so far? Did you experience any blood anywhere? So the reasons here for the hematuria are: number one, blood disorder; number two, UTI; number three, bladder cancer; number four, warfarin overdose. I excluded the warfarin overdose through the INR. My mission in the history is to ask few questions to find out the reason. To ask about number one, hematuria causes; number two, about the warfarin itself; number three, about any trauma; number four, any blood disorder. Those are the most relevant things to be asked in the history. What else? I need to ask about the lifestyle. Yeah, it's a relatively new station. It was not found in Aspire, I think. So number five, I need to ask about the lifestyle. What is the important question to be asked in the lifestyle, Dr. Muniba?
Change in the diet.
Perfect. Change in the diet is the most important question. Why? Because you know from the previous station that any change in any major change in the diet is one of the reasons to interact with the effect of warfarin. And also on alcohol, any binge drinking, or how much does she drink. The history here should not take you more than 3 to 4 minutes. This is short station. Move to the disclosure. Tell the patient that your test results show that you're having a condition we call microscopic hematuria. Why does this happen to me, doctor? Or what is this condition? It is a condition in which there is fine blood in your urine, which is not visible by the naked eye, only detected in the urine sample. Blood in my urine? Why does this happen to me, doctor? Is it because of my warfarin? You would tell her that, may I know why you think so? Doctor, because I know that warfarin causes bleeding. Now, at this point, you will tell her that it is not because of warfarin, because we test your INR, which is how long it takes your blood to thin, and it was within the normal range. So this is not a possibility, or this is not because of warfarin, definitely. So why, doctor, why it could be? Now you will tell her that we need to run further investigations. Which investigations? I will inform my senior, and we can consider doing some other urine tests for you. We can do some urinary culture if there is any bug in the urine, because one reason is UTI. Second thing as well, we need to repeat your kidney function test. Okay. Number 3, we may need to do some scans like ultrasound or CT scan when your urinary tract as well, if there is any stone, if there is any growth or anything. And ultimately, we can if the investigations are inconclusive, we can refer you to specialist to perform camera test, which is cystoscopy. So again, urine analysis, urinary culture, and you can also do clotting screen to see if she is having any blood disorder. So number 3, clotting screen or blood screen. Number 3. Number 4, CT scan and the ultrasound of the kidney, and ultimately refer to no. And ultimately refer to specialists to perform the cystoscopy. This is a good point, Dr. Kashi. You can refer to specialists for the scan and the cystoscopy. This is my fault, or this is my bad. You can I forgot that this is GP. So you can refer to specialists for scans and cystoscopy. Cystoscopy, why cystoscopy? Because we need to find, this camera test is going to visualize inside your urinary tract, especially your bladder, going to visualize inside your bladder to see if there's any abnormality from inside. So the core of this station is to know that you do not, you refer to specialists. Why? Because actually sometimes you need to do cystoscopy and some scans. Why? Because cystoscopy is done by specialists. If all the investigations came back normal, still you need to find the reason for the microscopic hematuria. So you need to do more invasive procedure like cystoscopy. Was it clear? So the core of this station is to know that it is not because of warfarin, because some people will enter and say that it is one of side effects of warfarin. No, it's not a side effect because simply the INR is normal. If the INR was low, if the INR was high, this means that it is because of warfarin. Otherwise, everything else is fine. Has anyone got any question regarding this station?
Brother, in this session, we don't have to talk about how to take this medication.
No. She's already taken it and she's regular with it.
Okay.
This station is just urine analysis. Test results. So she's here for her test results only. This is what you can do. If you don't mind, Dr. Ahmed, add this station to your notes. Perfect. So is this station the warfarin? Which one? Is this one exactly? This one the hematuria?
Yes, doctor. This one, yeah.
Okay. The warfarin with hematuria. What about the other warfarin ones? Were they clear?
It's okay, but this is a new one.
Oh yes. Actually, it's not new, Dr. Islam. It's from August and even July, late July. But I don't know why some people do not offer these scripts. I don't know. Don't worry, it's very easy, but now you know that it is the core of this station. It is that, it's not because of warfarin. Okay. Can I ask? Yeah, you can ask sore throat as well. You mean for the for the post-infectious glomerulonephritis, right? Post-infectious glomerulonephritis. Yeah, you can ask about it. No problem. Okay. So here the causes are, we told about them, and those are your DDs or your differentials that you need to follow. Number one, ask about the relevant things, the hematuria things. Number two, you can ask about the DVT itself, the condition. Number three, ask about the warfarin itself. Very important question to ask is any extra dose. And after that, you can also ask about the lifestyle, the smoking and diet are very important. And of course, any trauma or any injury. Why break? Why you need a break? You need a break, Dr. Elvira, or you need me to take break? Tell me honestly. Dr. Elvira, no, say that you need break. You need break, but not me. I will finish this station, which is related to warfarin as well, and we will be remaining with very simple stations for today. No, we're not allowed. Actually, the next stations are all diabetes. They are all similar approach. Okay, you can take few minutes break, no worries. We are going to explain the warfarin, and this station is very easy as well. I will tell you the idea here about it. It is warfarin and clarithromycin. So here in this station, simply, that's good. This is the chemical or the biochemical explanation. This is enzymatic inhibition, but you are not supposed to say this to the patient. You simply say that the combination of clarithromycin and warfarin will enhance the effect of the warfarin. Okay, in this station again, you are FY2 but working in GP here. Okay, the patient has come to 2 weeks ago to the GP here, and he was having chest infection. He has been prescribed clarithromycin for 1 week. Okay, and now he is, I mean, when he started taking clarithromycin, he has some test, or he is here to take some test results. So here he has done some test results, and his INR showed that it's high. The INR is 6. The INR is 6. Okay, okay. So the INR here is high. Do you have any idea why the INR is high here? The INR here is high because of the combination of clarithromycin and warfarin. Clarithromycin enhances the effect of warfarin. Why he was prescribed clarithromycin? Because of chest infection. Okay, so now you will take history from the patient. I'm here for my test results. Now take history from him. Which history you are going to do? I told you before how to tackle any counseling station. Right now, number one, if there is test result, you will pick up the important findings or the positive findings from the test results and ask about them in history. For example, why did you have this test results? He will tell you, doctor, I'm here for my regular checkup. Which checkup? He was having DVT and atrial fibrillation, and he is also having some factor V Leiden, factor 8 Leiden, factor 5 Leiden thrombophilia, sort of thrombophilia. He's having many things. This guy is having many diseases. So what we can do here is that number one, I'm going to ask him, why did you have this test as a part of my review? Which review? DVT. Now ask about any symptoms of DVT. Do you have any pain, any swelling in your legs? What were you prescribed for DVT? Do you take it regularly as prescribed? Any extra dose? Because extra dose is one of side effect, or high INR is one of the reasons for, or one of the complications of extra warfarin dose. Okay? Okay. Now I elaborated the DVT and the warfarin. From the task results, you know that he has been prescribed clarithromycin and for his chest infection, and he is having atrial fibrillation, and he is having factor 5 Leiden thrombophilia. So now move to the past medical history. In the past medical history, you have to ask him how was his health recently. No. Dr. Elvira, excuse yourself right now. I just saw your message. I'm sorry. I was not concentrating. You go to them and I will explain this station to you further in person. No problem, really. This station, yeah, it's important, but you know, it's cool right now. So go right now and explain it to you later, like after we finish the session. After we finish the session, I can explain it in 10 minutes later. I mean, just in 10 minutes after the session, no problem. Or even 5 minutes, it's easy. So in the past medical history, you will ask about recent health. He will tell you that he was having chest infection and he was prescribed clarithromycin. He has been taking all the doses of clarithromycin and he has finished the clarithromycin and his chest infection is better right now. Ask about the medical conditions. He will tell you he's having factor V thrombophilia and he's also having atrial fibrillation. And both things are managed by warfarin. So there are many reasons for him to take warfarin here. Sorry, he is not having DVT. I'm sorry, I forgot. He's just having atrial fibrillation and factor V Leiden thrombophilia. Okay. So he's here for his warfarin review, and he has taken clarithromycin a few weeks or 2 weeks back, and he is having atrial fibrillation and factor V thrombophilia. To elaborate any disease, when was it diagnosed and how is it managed? And do you take them regularly as prescribed? Okay. Now, ask also in the lifestyle, very important to ask about the diet and alcohol, because there are the things which can raise the INR. Okay? Now, very important part, move to the concern. Disclose the test results to him. Tell him that we found that your INR, which is how long it takes your blood to be thin, is high. Why does this happen, doctor, to me? Now you will tell him, I'm afraid to tell you that this is because of the clarithromycin you have been prescribed. Oh my God. So how could he prescribe this clarithromycin to me? Now you keep apologizing. You don't have any, it is sort of ethical as well. You have to keep apologizing. I have to talk to him to find out what happened. Definitely. We'll come back to you. I need to know why. I need to know why. Okay. So simply, you will have to apologize for the error. It's sort of error because he prescribed clarithromycin. Doctor, so does this mean that I could have bled to death? Well, I'm sorry, this is one of side effects of warfarin as well. But the good thing is that you came here for the follow-up and you did not have anything. One of the questions you can add in your history as well is to ask, have you experienced any bleeding recently? Any blood in your urine or any blood in your stool? You can add these questions in the history as well. Why? Because with high INR, the chance of bleeding are higher. Okay. So you will keep apologizing to the patient as well. You will tell him what you are going to do in this case. First of all, by the way, it was prescribed by locum GP. Who is locum GP? He's a GP who's a very qualified and competent person who is here to cover any absence or cover any shortcomings or any doctor who are absent for the day. Okay. Now you will tell him, he will ask you, doctor, but why didn't he ask me? Or why didn't he, you will definitely talk to your colleague and find out what happened. Yeah, he has prescribed and ran away. So you will talk to your colleague. But one thing, you have to tell the patient that, have you by any chance told him that you're taking warfarin? No, I didn't. Should I? Well, actually you should. I mean, any doctor should ask the patient about the warfarin or about any medication they are taking. However, we always advise our patients to inform about their warfarin intake. And that's why we always advise that you take the alert card. Remember the alert card? Did you give him the alert card or you show him the alert card? He will say no. Actually, that's why we advise our patients to show the alert card to the doctor. Okay, doctor. So what are you going to do right now? Now I'm going to talk to my senior to review your medication, or sorry, to see or to reach the best possible decision about your treatment. Now the examiner will tell you, after you say that I'm going to talk to my senior and check my book to find what we can do, you will talk to the senior and check with your book. Now the examiner will give you a paper. It's called Anti-Coagulation Protocol. What is this paper about? You will see in this paper that when the INR is above 5 and there is no major bleeding, what you can do, you will excuse yourself from the patient and read the paper. Excuse me for a moment, I'm going to have a look at my notes, and then you will read the paper and you'll find out that you have to stop the warfarin right now because the INR is above 5. So stop the warfarin right away, okay, till the INR becomes 5. And when the INR becomes 5, you have to start back again the warfarin on reduced dose. Again, you will stop the warfarin until the INR becomes 5. And after the INR is 5, you have to start on a reduced dose till the INR back again to 2, which is the therapeutic dose for the patient. Now you can resume the normal dose. So again, stop till it becomes 5. When it becomes 5, you have to start on a reduced dose. And when it becomes 2 or 3, you can start back again the normal dose. He will ask you, doctor, you will stop the warfarin, will I get a blood clot? You reassure him that you cannot get a blood clot unless your warfarin falls below the therapeutic range, which is 2 to 3. So you are not going to get a blood clot unless your INR falls below 2 to 3. We're going to monitor you as well. We're going to check your INR every day. Okay. At this time, you apologized and you offer solution. Now he can ask you, doctor, so this doctor, all this is because of this doctor. Really, I cannot imagine. Could I get bleeding, doctor? You will tell him that actually bleeding is one of side effects. Again. But however, we advise you that if you get any severe headache or if you're involved in any accident, please come back to the A&E. What are you going to do? Or if he asks you about the GP, the locum, he will say, oh, locum, who's locum? You will tell him that he's qualified, competent GP who is here to cover any absence or any shortcomings in the list temporarily. The patient sometimes can ask you, doctor, I'm not happy. You will tell him about the instant form. You can fill instant form in this case. You can safely fill the instant form. Why? Because this is sort of like, it's not wrong, but it's not true. Not true prescription or not right prescription. So it's not wrong and not right. So again, he should have showed the alert card to the doctor, and the doctor as well should have asked him about warfarin. So this is mutual mistake. Still, you can fill instant form. This is a station very simple, and it's very simple station, by the way. But the core here, I have a good idea. You know why the people, when it first came, I mean, most of you can wonder how was the reaction of the people who had this station for the first time. I mean, when it came for the first time, I will tell you something. They scored even higher than you. Because I'm sure in this station, if you open the BNF, you will find that you can open in the clarithromycin section, or you can open in the warfarin section. And you can find that there is an interaction, or the cautions say that you cannot prescribe warfarin with clarithromycin because of the drug interaction. So if you open the BNF and find that, you will simply get to know that the high INR is because of the clarithromycin. Very simple. And when you know that it's because of the clarithromycin which was prescribed in the hospital, you will keep apologizing to you, the patient. Very simple station, Dr. Elvira. But please understand it very well, because this is not present in every script. No, there is no time limit here in this station, Dr. Islam. Your history will barely take you 4 minutes. And the management, no, the BNF, it will take you only 20 seconds or 30 seconds. and you will only keep apologizing, offering solution, and instant form. This is the station so far. If you open the BNF in this station, you will reach very good marks. I mean, even your history can be only 3 minutes. 3 minutes history is very enough. Don't worry about that. I like IELTS reading, remember? Like IELTS reading to say, you have to be skimming and scanning. No, actually, in the BNF, it's very simple to open it. And what I do recommend is that in the next days, inshallah, guys, you will open it on the soft version, on the e-version. In the e-version, if you try it on the e-version or the electronic version, actually, you will be easily tackling, or it will be very easy to you on the hard copy, because soft version is not easy. So if you train yourself on doing it in few seconds, in the soft version, you will be likely finishing it even earlier in the hard copy. So these are the warfarin stations. Has anyone got any questions so far? Anyone has any question or has anything to ask about here in these cases?
Hello, hello, it's Fumi.
Huh? Excuse me?
Hello.
Fumzi.
Hello.
How are you, Fumzi?
Hello, it's Fumi.
Fumzi, let's say Fumzi.
I'm good, thanks. You?
I'm fine too.
Yeah, I was just wondering about the warfarin.
Your voice is interrupting. Say again. What about the warfarin?
Hello.
Yeah, tell me.
Can you hear me?
Yeah, I can.
I was saying that we have the alerts book.
Hello. I think,
Hello?
guys, does her voice interrupt to me only or to everyone? Okay, tell me again. Tell me again.
I was saying that there are 3 books for the warfarin stations, right? Especially the one with the learning disability.
Yeah.
Right?
Yeah.
There's an alerts book. There's a record book. What's the 3rd one?
The leaflet. It's not a book. It's just a warfarin leaflet. Leaflet contain all the information.
Oh, okay. Okay.
Okay, this is,
Thank
it's
you.
not 3 books. It's just called, all together are called Anticoagulation Folder. And by the way, you will find it beside you by the table in the cubicle. So please remember to pick it up, because when you are explaining, you need to pick it up to show it to the patient. Do not speak only, do not verbalize. No, you have to show it to the patient. So pick it up from the table by your side.
Okay.
Okay, Dr. Fumi. And by the way, it was nice hearing your voice. It's very long since hearing your voice the last time.
Thank you.
You're welcome, Dr. Fumi. Okay, so let's move to other stations as well. What are the other stations? Diabetes stations. Before moving to diabetes, I need also to discuss one interesting station, which is the celiac disease. Because I need to finish the celiac disease stations. Sorry, there are 2 stations, by the way, for celiac disease. I will discuss at least the 2 of them right now. And the last 1 hour in the course today or in the session today will be for the diabetes stations. I will discuss the celiac disease and the statin as well right now. By the way, tomorrow, inshallah, tomorrow will be left only with 2 or 3, with 3 or 4 counseling stations only. And we can start the next compartment, which is the surgery. We will start tomorrow by surgery counseling and some of the surgery history. We will be finishing surgery in the day after tomorrow, inshallah. We will be left with OBG and pediatrics. Okay, we can finish the OBG and pediatrics in 1 day, but I will make it to you 1.5 days, because other people also need to chance to study some other things as well. And in the next 2.5 days, or in the last 2 days and a half in the course, we'll be discussing the combined stations, like how to explore them and how to tackle them, but quickly, of course. And we'll be also discussing the SIMMAN stations. SIMMAN, I will send you the recording, you all. I need you to listen to the recordings very well. They will barely take you 1 hour and a half. After listening to them, you will come to me and you will see Dr. Elvira and Dr. Muniba when she is performing some of the same manifestations. All right, Dr. Muniba? And Dr. Yasmin as well, and some other people, because I think like 8 or 9 or even 10 people of you will practice the same. It will be pure practice day. So all of you will practice SIMMAN at least here with me. Of course, Dr. Masi, I said most of you will practice. I mean, this will be pure practice session, SIMMAN session. No need to be scared, Dr. Masi, of SIMMAN. I will send you the recording and please memorize them by heart and go. Okay. So let's speak about the celiac disease. Brother. So let's speak about the celiac disease. Dr. Muniba knows better. I think Dr. Elvira and Dr. Islam, you are the first. Yeah, you are the first together. Dr. Elvira and Dr. Islam. No, Dr. Muniba knows better because she has got some idea before. She has got some experience before about SIMMAN. Right, Dr. Muniba? Anyway, so Dr. Elvira and Dr. Islam are having in 23rd May, I think, and other people are later, either in far May, in the end of May, or June or July. Okay, so this station is celiac disease station. What about the celiac disease station? You will find that this patient has been having some episodes of tiredness and diarrhea, and that's why she went to the GP. And the GP has prescribed her or has asked her. He used to teach her. He used to ask her about her history, and he prescribed for her some blood tests. Which blood test? He prescribed for her GGT. Sorry, not what was the name of the test? I forgot. Oh my god. The initial test. The initial test for celiac disease. I always mix it with the GGT.
Transglutaminase.
Yes, transglutaminase. Yes, transglutaminase. So he prescribed or he asked it for her transglutaminase and it came positive. So the transglutaminase came positive and he referred her to the medicine department for which she is supposed to have endoscopy. By the way, why do we ask endoscopy for such patients? Because simply the blood test is not confirmatory, it is just suggestive. Any antibody problem or any autoimmune problem, especially in the bowel, you better do endoscopy for it. The transglutaminase came back positive, and now you have to do endoscopy to confirm. Here the lady is here because she's having some concern. So now you will enter. Why or how can I help you? Doctor, I'm here because I'm having some concerns. My GP, yes, endoscopy and biopsy, Dr. Muhima. I will tell you right now in details. She's having some concern. Which concern? Doctor, I have been referred by my GP here because he sent me to a camera test and I don't need to have this camera test, or I need to know why are you going to give me this camera test. I'm here to address all your concerns, but please let me ask you a few questions. Which questions I'm going to ask? I'm going to ask her, may I know why did you have or why did you go to UGP in the first place and to have this test? She will tell you, doctor, because I was having diarrhea and tiredness. Now you elaborate the diarrhea and elaborate the tiredness. Very important thing while elaborating the diarrhea to ask her, has it come after certain type of foods? How did you pick up this question? Because you know from the task and the test result that the transglutaminase is positive, which means that celiac disease is found or suggested. So ask her, does it come after any specific time of food? She will tell you, yes, doctor, when I'm eating any rice or bread or any whey or barley. any gluten-containing food. Okay, so you will elaborate the tiredness, diarrhea, and tiredness. You can also ask her about 2 or 3 more symptoms, like any tummy pain, like any bloating. Have you had any, like, remember the associating symptoms to diarrhea? Any episodes of constipation in between, any weight loss, any loss of appetite, because the differential cell could be cancer, could be IBD as well. So just ask 2 or 3 more questions, and usually she may not let you take long history because she's concerned about the endoscopy. But it's important to ask at least some questions to gain marks in data gathering. Ask about the lifestyle. In the diet, she will tell you, I eat everything, doctor. Okay, so now you can also ask her about the 4P, like the period of pregnancy as well. It's not very important here because actually this is counseling station. She will push you toward endoscopy. So what are you going to do right now? You're going to tell her, may I know what's your concern exactly? She will tell you, doctor, I need to know why we're going to do this, and you are going to do this camera test. You will tell her that we need to do this camera test to confirm your diagnosis. Your GP was suspecting something we call celiac disease. What is this, doctor? It is a condition in which, it is an autoimmune problem in which your gut reacts to certain type of food. So this, when these certain types of food are introduced to our body, there have been some immune reaction, some antibodies are produced, which are chemicals. Those antibodies fight against our own tissue, our gut tissue. And that's why you have this inflammation in the gut. And that's why you're having this diarrhea. So again, autoimmune problem, our immunity, instead of fighting against foreign substance, sometimes it fights out against our own tissue. And this happens because of the food, some certain type of food which are introduced to you. In your case, gluten-containing food. Why did I have it, doctor? Usually no reason. Sometimes family, transient family, sometimes no reason. Okay. So why the endoscopy? We need to do the endoscopy here in this case. Why? By the way, she can ask you in the middle. So doctor, it's a food allergy? It's not a food allergy. It is just an autoimmune reaction triggered by some certain type of food. Do you know the difference? The food allergy, guys, is a generalized allergy. So it will cause hair rash and shortness of breath, lip swelling, like anaphylaxis. It can cause it. But here it's not food allergy. It is just autoimmune reaction inside the body. Why do you need to do endoscopy? Because this endoscopy will help visualize the inside of your bowel and also take a sample from your bowel or your gut, your intestine. Why biopsy, doctor? Because we need to see the inflammatory changes in your gut, which can be associated with the celiac disease. What are you going to see? The inflammatory changes. Doctor, is it cancer? May I know why you think so? Because doctor, one of my friends, she has got some diarrhea and weight loss and she was diagnosed with cancer. Actually, your symptoms are not suggestive of cancer at all. However, also we need to do this endoscopy to confirm the diagnosis and as well to exclude other causes. Doctor, but I don't want it. May I know why? So basically, she's having some concerns. Her concern is that sometimes the endoscopy can be painful. What are you going to do? We are going to numb the area and we can put you, or we can give you mild sleeping medication. This is number one. Number two, second concern. Does it have any complications, doctor, the endoscopy? You would tell her that if you are giving you some sleeping medication, you can experience some dizziness, for which we need to keep you for more hours in the room here to observe you, and we are going to make sure that you do not sign any heavy sign any important documentation or operate any heavy machinery, like warning signs for any disease. Sometimes it can cause infection, for which we can give you antibiotics, and some slight bleeding, which will heal on its own. Doctor, what else she can ask you? Doctor, so what is the importance of this endoscopy? You told her the endoscopy is to visualize the inflammatory changes and also to take a biopsy to confirm the diagnosis and to exclude other causes. What is the use of this biopsy, doctor? Like any biopsy, we send it to the lab for further examination. Doctor, but what will happen if I do not have this endoscopy? We cannot start the treatment properly. And what will happen, doctor? What will be the treatment? The treatment simply is some supplements here, like iron supplements and vitamin D and calcium supplements as well, and some jabs. Why? Because actually the continuous diarrhea can lead to some osteoporosis on the long run and lead to iron deficiency anemia and hyposplenism. Those are the three complications of celiac disease: iron deficiency anemia, osteoporosis, and hyposplenism. So if she does not confirm diagnosis, she is not likely to start the treatment properly, and she may end up having the complications. Also, one important part of the treatment is that she may need to restrict gluten in her diet. Actually, she should abstain from gluten. Do not waste much time about this. Just say, we can refer you to a dietitian who guide you about the most suitable food or diet plans in your case. He can guide you about the food which is not containing gluten, because you will not be having too much time to cover this item. So again, the concerns. Number one, what is celiac disease? Number two, I don't want to have endoscopy. Why? Could be painful. Why? Could be having some complications, and offer solution to each complication, if she asks. Number three, why is it important? Because we need to visualize, and we may need to take a sample from inside to examine it under microscope. What will you see? You will see the inflammatory changes. Is it cancer? May I know why you think so? She will tell you something. Okay, so from your symptoms, it's not suggestive of cancer at all. However, we need to do this to confirm and also to exclude some other conditions, and cancer one of them. Okay, sometimes she can ask you this question. So doctor, why didn't my GP advise me about not eating gluten-containing food? I mean, why didn't he advise her to abstain from gluten? Because she needs to take the gluten-containing food before she has a test. Why? If she abstains from the gluten-containing food, the bowel or the gut will be quite normal. So we will not be able to visualize any inflammatory changes in the gut during endoscopy. So to confirm diagnosis by endoscopy and for the biopsy, we need you to resume or to continue your normal dietary intake. Okay, what is the importance to confirm and exclude? What will happen if she does not have it? She will end up having one of the complications like iron deficiency anemia and osteoporosis and hyposplenism. The treatment for celiac disease when it's confirmed is number one, gluten restriction. Number two, some supplements including iron and vitamin complexes and jabs. Why jabs? Because the chance of hyposplenism. By the way, this came recently with a little bit of twist. What is the twist recently? Is that she is not yet hyposplenism. Most likely she will be having hypo, why? Continuous diarrhea and loss of many components. So she will end up having low immunity. Jabs. Very important to give her jabs, including meningococcal, pneumococcal, and flu vaccine. One important thing is that here in this station there come a twist recently. Which twist? The twist here is that the patient did not go to the GP. Okay, so she did not go to the GP, so this is a history-based station, not counseling station. So you are diagnosing celiac disease from the beginning. How to diagnose it? You can simply take some history from here, usual history, rule out the DDs which are IBD and cancer. And in the middle, she will tell you that all these things started after taking gluten diet. And she is having some family history of celiac disease as well. So right now, I will tell her that I'm suspecting that you're having celiac disease. Okay. However, we need to run further tests. Which test? Some blood test, which is suggestive, and after the blood test, we can refer you to endoscopy. Very similar station to the past one, but the thing is that only you will add that we need to do some blood test, which is suggestive, or to see the possibility of having celiac disease. How to pick up celiac disease from the history? Diarrhea, which starts after certain type of food, and prolonged diarrhea, by the way, like long-standing diarrhea, which starts after certain type of food, together with some tiredness and family history of celiac disease. This is the only twist. And it's very easy and quite straightforward as well. Okay. So, has anyone got any questions so far? Let's move to one interesting station, which is the asthma discharge station. The asthma discharge station, some people will consider it one of the most big stations. Actually, it's the easiest counseling station among all stations. Why easiest? I'll tell you why. Because the guy is very helpful. The guy is really helpful. This guy is like, he will help you if you provide or if you give him like good report. Okay, so in this station, simply the guy is coming. He has been admitted in the hospital a few days back. Okay, and he has been diagnosed with asthma, and he is going to be discharged right now. So this is the first diagnosis. I mean, he is already diagnosed right now, but he's going to be discharged after a while. Okay, in this station, simply I need to ask you one thing. I need you to write in your own notes right now that in this station, this is a discharge station. Before any discharge of any patient, we need to take, number one, history of the relevant condition, like history of asthma here. Number two, examine the patient. Of course, number one, history of the relevant condition and past medical history. Number two, examine the chest, full chest examination. Number three, do PEFR, peak expiratory flow rate, which is your investigation here. So history, examination, and investigation. From the history, no symptoms. From the examination, chest is clear, no wheeze. From the PEFR, the reading is fine. So this patient is fit for discharge. Before discharging him, you will give him some few advice. Which advice? Number one, advices regarding the medication. Like what? I will tell you like what. Here you will tell him that you need to take these two medications, blue inhaler and brown inhaler. Tell him how to take them. This is number one. Or sorry, tell him about them, like the importance and the effects of them and side effects. Number two, you will tell him how to take them, like the mechanism of taking the inhaler. Number three, the PEFR or the asthma diary. Again, number one, you will teach him about the medications and their side effects. Number two, you have to teach him how to take the medications. Number three, you have to tell him about the asthma diary. So this station is 6 compartments, 3 before discharge and three after discharge. Please write here that your history should not take you more than 4 minutes. The history should not take you, I mean the history including the PEFR should not take you more than 4 minutes. Okay. Here in this station, simply, you will ask the guy, how can I help you, doctor? I'm going to be discharged. Well, that's great. I see that you're happy and excited about discharge. Now, you will ask him a few questions, like, for example, why were you admitted to the hospital? He will tell you that I was admitted because I was having some shortness of breath. And how was it managed? Doctors, they gave me some oxygen and some inhalers like salbutamol inhaler and this thing. And how are you feeling right now? Do you have any shortness of breath, any wheeze, any cough? See, this is 1 minute. Number 2, do you have any, move to the past medical history. Do you have any, how was your health recently? It was definitely having upper respiratory tract infection recently. So this is the recent health. Do you have any other medical condition? No. Do you take any medications? No. Any family history of any problem? No as well. So this is a past medical history. Ask about lifestyle. So you spend here 2 minutes in the history. Now, examine the patient, including chest examination. The examiner will tell you, doctor, chest is clear. Number 3, you will tell him this is an instrument or this is a device we call peak expiratory flow rate. Do you know about it? If you do not ask this question, do you know about it? If you did not assess his idea about the PEFR, you will end up spending at least 1 minute trying to explain the PEFR and how to use it to the patient. So better ask him, do you have any idea about it? He will tell you, yes, doctor. Or he can tell you, no, doctor, sometimes. So you will say that this is a device we use to blow or to check your ability on blowing the air outside of your lung. Do you know or have you been told about how to use it? He will tell you, yes, doctor. Otherwise, if you did not ask this question, you will start explaining it to him and you'll be wasting some time. So usually this guy knows how to use it and he knows as well about it. I mean, its importance. So if this guy knows how to use it, do you need to explain how to use it? No. You will just tell him that, may I see how you can use it, please? Or can you show me how you can use it? So you need to check his demonstration. Suppose that he does not know how to use it. What you are going to do? You are going to tell him that, number 1, you need to hold it in upright position, in horizontal. You need to hold it horizontal. Okay, let me open the camera here because I need to show you something. I am supposing that this is PEFR device with me. Just give me a few seconds. I'm supporting that, and by the way, you can check it on Geeky Medics as well. It's very obvious on Geeky Medics, and it's very easy, by the way. And make sure that you see it in the academy before. Okay, let's suppose that this is the PEFR. Okay, let's suppose this is a PEFR. You're going to ask him to hold it horizontally like this, not like this, not like this. Okay, it has to be horizontal. Okay, has to be horizontal like this, and he has to make a tight seal around his mouth. Tight seal. Here comes a problem. Most of the people forget one thing, one important thing, and this thing is not very important to you, but it's very important to the examiner. You have to change the mouthpiece. You know, this PEFR is having mouthpiece around it. I mean, from the piece or from the portion that you're going to make a tight seal around your mouth, there is a mouthpiece which can be changed. You have to change it before demonstrating it to the patient. You see how they mind about this stuff? Yes, they do mind about this stuff. Why? Because this shows either you are safe doctor or not, either you are clean doctor or not. I had been told recently that the cameras outside, even the cameras outside, they are observing you if you are washing your hands before each cubicle or not. This is very important. Do not underestimate these things. Yes, you are assessed upon many things. So you have to wash your hands before entering any station, especially if it is combined examination station. Okay? So these things like the PEFR, there is a tight seal around it, or if there is a mouthpiece in the end of it. You have to change the mouthpiece simply, take it off and discard it in the recycle bin here, or the clinical waste bin, and ask for another mouthpiece from the examiner. He will tell you, doctor, there is a mouthpiece here. So see, this will only take you 5 seconds, but this can fail you the station if you do not do it. So make sure before demonstrating to the patient, you have to change the mouthpiece. Now, you are going to make a tight seal around the mouth like this. You will be holding it like this maybe. You can hold it the way it relaxes you or it comforts you. Hold it like this, make a tight seal around the mouth, hold it in a horizontal way. Okay? Take normal breath and then blow out as forcibly and as fast as possible. As quick and as forcible as possible. As quick and as forcible as possible. Okay? Okay. Now notice the reading, which is on the scale. One important thing, before blowing, you have to set the pointer or the scale back to the start point, which is 60. The start point here is 60. It is written on the scale. You have to pull it back to 60. And then blow out as fast as possible and notice how the scale goes. Okay? Okay. So now you measured the PEFR reading. He will do it 3 times in a row, and he will pick up the highest reading in them. He will pick up the highest reading in them. Okay? Okay. In this case, when he picks up the high reading or the highest reading, he will record it on the curve. What is the curve? He will provide you with a paper, and this paper will contain the age of the patient and the the age and the PEFR. It is a curve. I will send you a photo of the curve right now, or after the session, I can send you a photo of the curve, and we are left with the BNF from yesterday. So I will send you a photo of the curve of the PEFR. Simply, you will see the age in one axis and the PEFR readings on the other axis, or the other line. Meanwhile, there are some curved lines. These curved lines are for the age, for the height, and for the gender. So you will ask him about his height, and he will tell you, for example, 175. Now you will close, or you will do 2 intersecting or 2 lines, and you will see how his PEFR reaches. I mean, you will get his normal PEFR reading and compare it, or you will get his supposed or therapeutic PEFR range, and you will compare it with the reading he gave you on the PEFR. Usually the PEFR reading is normal here. I mean, his reading is normal. His reading should be at least 75%. I mean, for example, if he gave you 75 and his reading or his predicted reading should be 100, this is fine. So up to 75% of his normal reading is fine. But if he give you maybe 74% or 74, the reading is 74, and his predicted value is 100, this means that it is low PEFR. So again, the PEFR reading should be at least 75% of the normal reading. Usually he will give you 90% of the normal reading. Okay. He will repeat it 3 times, and you will record it, of course, and you will demonstrate, or you will use the curve to reach the best possible value. Now you will know from the history that the patient has no symptoms. The patient as well, chest examination is quite fine, and the PEFR reading is quite normal. So this patient is fit for discharge. So now you will tell him, I can see that you are fit for discharge. Okay. Please, one important thing also, when he is trying to do the PEFR, when you ask him to demonstrate the PEFR to the patient, I mean, after demonstrating it, you will ask him to do it, to perform it. When he is performing it, sometimes he can do some mistakes. Like what? He is not holding the PEFR in the right way, or he is not blowing forcibly. He is not making a tight mouth seal. He can be not sitting upright. Always mind this point. He can be like bending forward. He can be very relaxed. No, he needs to sit upright for the chest expansion. So please watch him while he's doing it and correct any mistakes. So now he is absolutely fine, fit for discharge. You need to tell him about 2 or 3 things. What are these things? Number 1, you will tell him that we are going to give you some inhalers. Blue inhaler and brown inhaler. What are these inhalers? You will explain that the blue inhaler is to dilate the airway. Dilate the airway by relieving any obstruction in the airway. And it will be taken when needed. Okay? The doses are written in the discharge summary. In this task, you will be given a discharge summary or discharge paper by your side in the table, and you will see the dose of salbutamol, and it's usually up to 2 puffs per day when needed. Up to 2 puffs per day when needed. What are the side effects of the salbutamol? Simply some hand shaking and some heart racing and some headache. And usually it wears out after, or it wears out after some time, which means that they are temporary. Okay. What about the corticosteroid inhaler, the beclomethasone, or just the steroid inhaler, the brown inhaler? You should use it every day. Why every day? Because it acts by building the level in the blood to protect or to provide suitable immunity. And it reduces the inflammation and swelling in the airway. So he needs to take every day. How many times every day? He needs to take, here in this case, he needs to take 4 puffs twice daily, which means 4 in the morning and 4 in the evening. If you are confused, refer back to the discharge summary, and you'll find everything is written in the discharge summary. It depends on the doctor prescription who discharged him. Side effects of this beclomethasone, sometimes mouth problems, like for example, fungal infection in the mouth, as you know, after any steroid, local steroid. So in this case, actually, he needs to rinse his mouth after it, like wash his mouth and wash his teeth. How to take it? Very simple. How to take it? Number 1, you have to shake the inhaler. Very good. Number 2, or before shaking the inhaler, you have to check the expiry date. Number 2, shake the inhaler very good. Number 3, you will remove the cap which is over the mouth portion or the mouthpiece. And then you will take a deep breath. Sorry, you will blow out gently. You blow out gently. Make a tight mouth seal and take a deep breath. So again, shake it, remove the mouth cap, blow out gently, make a tight seal around your mouth, breathe in gently. Press the canister, of course, press the canister, which is the inhaler itself. Press the inhaler and take a deep breath. Hold your mouth or close your mouth for a few seconds, at least 5 seconds after it, or 10 seconds sometimes, and and breathe in deeply. This is the inhaler technique. So now I taught him about the medication. Now I need to speak about something called asthma diary. What is the asthma diary? It is a sort of diary which we provide the patient, in which he has to do some few things. Number 1, he will be recording, or he will be doing the PEFR every day in the morning and in the evening. Remember, he has to do it 3 times. 3 times in the morning and 3 times in the evening. And each time he picks up the highest reading. So 3 times, pick up the highest reading, and other 3 times in the evening, pick up 3 readings, or pick up the highest reading. And he will record them in the asthma diary. You will find it in the cubicle. It's written the days of the week, and each day, morning, evening, morning, evening. So he will write the morning reading and the evening reading for each day in the week. Number 2, he has to tick the box if he has got any symptoms. For example, now is Saturday. He has to tick the box of Saturday if he has got any symptoms of asthma on Saturday, like if he has got any shortness of breath or any wheeze. Okay. He has also to tick the box or record any day. He has to tick the box if he has experienced any nocturnal symptoms, like while sleeping at night, even once, and if he experiences the symptoms more than 3 days per week, and if he uses the inhaler more than 3 days per week. So again, he has to tick the box if he used the inhaler more than 3 days per week, if he experiences symptoms more than 3 days per week, and if he wake up in the middle of night because of symptoms even once per week. What he should do if he get any attack or any episode. Simply sit upright, take the inhaler, okay, and record it in your asthma diary. And please, if you get these episodes more than 3 times per week, and if you get these episodes, or if you use the inhaler more than 3 times per week, and if you get them even once while sleeping at night, okay, come back to us. By the way, this patient should follow the GP within 3 days from now. One important thing we forgot is that one of the medications which can be prescribed is the prednisolone tablets. Prednisolone tablets will be taken for 5 days. He has already taken them for 1 day, so it will be taken for 3 more days, and the 5th day will be follow-up. So he will follow up, or he will come to the GP within 3 days from now. Okay, so he will come to the GP within 3 days, who will follow up his medication as well, and he will be followed up with a specialist after 1 month from now. So GP in 3 days, or two working days or 3 days, and he will be seen by a specialist within 1 month. Okay, so the asthma diary you'll pick up the asthma diary from the table and explain it to him again. If you have any symptoms, or if you use the inhaler, or if you wake up in the middle of night, come back to us and record it in your asthma diary. These are the asthma stations so far. It is a very easy station, but some people may consider it very long, though it is not long at all. The thing is that the people keep assuming that the patient cannot use the PFR, and they start explaining everything to him from the scratch. You should always ask his idea. If he's able to use this, you know this station will barely take you 7 minutes. But if you keep explaining everything from the scratch, I am sorry, it will take you so longer. Okay? Okay.
Hello, Dr. Ahmed.
Yeah.
This patient has been admitted in the hospital for last 3 to 4 days. So isn't it he must be knowing the method of PFR uses?
Yeah. But I mean,
confirm that are you comfortable using, like, instead of teaching PFR method technique here, this is the charge station, so expectation is more mainly for the inhalers, tablet, diary. PFR is a diagnosis station, isn't it?
Yeah, it is not diagnosis, but that's why you have to ask him.
Just ask.
Yeah, you have just to ask him, because sometimes he can tell you, no, I can't use it.
Yeah.
You are not sure. You do not assume anything. Do you know how to use it? Yes,
You'll ask, yeah.
Yeah. Okay. So this station is quite easy, but the people will spend too much time in it. Why? Because they keep assuming about these things and they never ask about it. And I warned you before many times that you should not ever assume anything for PLAB 2. Always ask the idea, much better than assuming anything. Okay? So one important thing here is that in this station, or in any general station for Inr charge, the approach for Inr charge is number 1, to check the health, to check the current status, the current health. Number 2, do examination. Number 3, do the relevant investigation. If everything comes back normal, you can discharge. But this charge is advised. Which advice? Number 1, here medications. Number 2, the technique of medications. Number 3, the asthma diary. Okay. So let's move to the diabetes stations. Diabetes stations, they are all similar. So please, if anyone has any difficulty while coping with them, because we are going to speak fast in them, all of them are normal. I will just pick up the differences. What are the differences here? They could be, the differences differ from one station to another. Like, for example, in my station, you will be doing some procedure like some laser photocoagulation, and in some station you will be saying that it's just not well controlled, and you will give some lifestyle advice, and in some other station it will be hypoglycemia. So please remember always that the hypoglycemia treatment, I have to tell you that in the hypoglycemia it is challenging. Some academics write it in the wrong way. The management for hypoglycemia, before we start the management of hypoglycemia, you have to ask the patient if he is able to swallow or not. You will check his status. You will check his status. I mean, if he is drowsy or very drowsy, definitely you cannot give him anything by mouth. So what are you going to do right now? If the patient is very drowsy, you are going to tell the patient that I will give you some injection, which is glucagon. But if the patient is a little bit drowsy, like he is talking to normally, and he is telling you like, doctor, I'm fine, but you know, I'm feeling drowsy. It's totally different from the patient who's telling you like this. So this patient, I mean the patient who is very drowsy, he cannot take anything by mouth. But if the patient who is just normally drowsy, you can tell him like, are you able to swallow? He will say yes. So now you can give him oral glucose tablets. So if the patient is very drowsy, you will start with IM glucagon. If the patient is normally drowsy, you can start with oral glucose tablets. What is the next step? Usually the next step is after oral glucose, you can give IV glucose. IV glucose or IV dextrose. Which dextrose you can give either 10% or 20% dextrose. So here, if you are giving 10%, you are going to give, for the 10%, you are going to give 200 milli over 15 minutes. Any IV, any hypo in the body, any hypovolemia, hypoglycemia, any hypo, you treat it in 10 to 15 minutes. So you will give IV dextrose 10% over 15 minutes. How much? 200 milli, if it is 10%. What if it is 20%? You will give only 100 milli. So 200 milli for 10% and 100 milli for 20%. And both are over 15 minutes. So let's start this station, the hypoglycemia station. You are FY2 in outpatient clinic, or yes, you are FY2 in outpatient clinic, and the patient has come here and he's feeling unwell. So the patient is feeling unwell, and the patient is diabetic. Manage the patient and talk to the patient and address his concern. You'll enter the cubicle, you'll ask the patient, how are you feeling or how can I help you? He will tell you, doctor, I'm feeling unwell. What is the first question you ask to the patient, Dr. Elvira? When someone tells you, I'm feeling unwell, what will you say?
Oh, what does he? Oh, what is it? What does he mean by unwell?
Okay, perfect. This is the question that I was asking. So if you ask this question, he will tell you, doctor, I'm feeling drowsy. Doctor, and he will show you that he is trying to be sweaty, and he is trying, like, for example, he is like stammering a little bit. So at this point, you would tell him, or he would tell you this thing. You would tell him, may I know, can you tell me more about that? What do you want to know, doctor? When did it start? How did it start? The patient will try to show you every time that he is trying to be drowsy, and he is not so cooperative. He is cooperative, but not so cooperative. I have a good idea, because there are many approaches to this station, but what I prefer is that when someone is telling you, I'm feeling dizzy, and you are seeing he's drowsy or he's getting drowsy, why don't you simply excuse him for a moment? I need to have a look at your readings or at your vitals. You will check the vitals and you'll find every vitals are normal. All the vitals are normal. So you could tell him, I can see that your readings are quite fine. Do you have any medical condition? He would tell you, yes, doctor, I'm having diabetes. Since when it has been there? How is it managed? He will tell you, I take insulin, doctor, for it. Do you take it regularly? Yes, doctor. Have you taken insulin this morning? Yes, doctor. Have you taken any meal after it? No. So how did I pick up that it's because of insulin and hypoglycemia? One question or one thing I made is that I had a look at his vitals. I had a look at his vitals and I saw that all the vitals are quite normal, which means that the only reason for drowsiness right now is hypoglycemia. So for the hypoglycemia, I am going to ask him, do you have any medical condition? He would tell you, yes, I'm having diabetes. Now elaborate the diabetes and ask him about the insulin and if he took the meal after it or not. Other approach, you would tell him that, for example, without checking the news chart or without checking the vitals, what are you going to do here? You will take history from him about the dizziness or drowsiness. When did it start? How did it start? Has it changed? You see that this patient, may I know why you came for the clinic today? He will tell you, doctor, I came for the clinic today because this is my diabetic review. And I see that you are dizzy. Why did you come to the clinic? Why didn't you go to the A&E? So he would tell you that, doctor, because I'm receiving insulin. So there are many ways to let this patient talk. This station, the core in this station is that you will not know that it's hypoglycemia till you ask the patient some questions. What I do recommend is that when you see any patient who is dizzy, pick up the news chart. When you see that all vitals are normal, so definitely this is because of hypoglycemia. So now ask him about medical condition. Do you have anything? Yes, doctor, I'm having diabetes and I've been taking insulin. Now, when you know that the reason of insulin or hypoglycemia, now I'm going to give you some things. Are you able to swallow? Yes. He is able to swallow. I told you, give him like dextrose tablets. 5 to 7 dextrose tablets. The examiner will tell you, assume, doctor. Before that, before giving this to him, you have, I'm sorry to forget, you have to measure his blood sugar. How to measure the blood sugar? There will be a glucometer on the table by your side. So tell him, I'm going to measure your blood sugar. Now you will open a prick and fix glucose strip in the glucometer, and then pretend that you are going to prick the finger. The examiner will tell you, assume, doctor, the blood sugar is 2.5. Normal blood sugar should be above 4. So he's having hypoglycemia from the reading. Now you will ask him, are you able to swallow? He will say yes, or he may say no. If he says yes, you will start by 5 to 7 dextrose tablets. The examiner will tell you, assume, doctor. How will he take them? Chewing them. He will chew them. Okay, what are you going to do now? I'm going to measure the blood sugar after 10 to 15 minutes from now. The examiner will tell you, doctor, the blood sugar now is, for example, 3.8. 3.8, this means that it's still below 4. So you have to give him IV dextrose over 15 minutes. The examiner will tell you, assume, doctor, the blood sugar is 4.5. Now you fix the hypoglycemia. You have to maintain him on long-acting carbohydrate. What long-acting carbohydrate here? Because you need to maintain the glucose level in the blood. You know, because this high glucose can stimulate insulin gush. So if after some time the insulin is high again, he will be having hypoglycemia again. So you need to maintain that glucose level in the normal. So you are going to give him long-acting carbohydrate, like maybe some bread or some milk or some sugary meal of his choice, or some biscuits. Okay. Now you will take some history from him, like for example, ask about the lifestyle questions. Now tell the patient, or the patient will ask you, by the way, make sure that you manage the patient here before moving to the management. How and why? Because actually, if you wait till the end of the station, the patient is already very dizzy and he's getting more dizzy by time. So you have to pick while your history taking that it is hypoglycemia. And when you ever pick it up, start your management as soon as possible. And then after you manage the patient and he is comfortable, now resume or continue taking history. Okay, you will disclose to the patient saying that, by the way, if the patient is not able to swallow, you will give IM glucagon 1 gram. and you'll measure the blood sugar after 15 minutes. Still low, you can give him IV dextrose 10% or 20% over 15 minutes. Same way, but here you will start with oral and here you will start with IM. Okay? Now disclose what's wrong with me, doctor, or now he is absolutely fine. By the way, after each step, you have to check his comfort. Are you fine now? Are you fine now? Are you feeling better now? In the end, you'll tell him that you had an episode called hypoglycemia. What is this? Low glucose level in the blood due to the insulin. You took insulin and you did not take meal, and that's why the glucose was low in your blood. Okay, doctor. What have you done to me? You will tell him that we give you, you will say what you have given. What are you going to do with me, doctor? 100 IV glucose or IV dextrose. IV dextrose can be 100 or 200. 100 or 2, yes, how many milli? 100 or 200. It depends on the concentration. Higher concentration is lower dose. For example, 200, for example, 20% dextrose. 20% is 100 milli, and 10% is 200 milli. And both are over 15 minutes. So we need to keep you in the hospital. Doctor, why? Yeah, I know what's your concern. Doctor, I need to, for example, to bring my children from the school. Say anything. Can't you arrange anyone else to bring them? Would you like us to help you with this? Anything. He will tell you, okay, usually he will accept. After that, we'll explain to him why we need to keep him in the hospital, because we need to keep monitoring your blood glucose within the next 24 hours. You need to monitor your blood glucose and your insulin dose as well. Why? Because actually he can get dizzy at any point. The hypoglycemia or the brain effect or the brain problem can last for up to 24 hours. So we need to monitor him at least for the first 24 hours. If you ever have time after this, you can warn him about how to spot the signs of hypoglycemia in the future. Like if you feel any, like certain nothing. If you feel any dizziness or sweating or any like hand shaking, this means that you are having hypoglycemia. So please keep something sugary or sweetie in your pocket all the time, preferably like some biscuits. Okay, and it's very important as well to warn him, like to, here in this case, to measure the blood sugar regularly by the glucometer, especially at the night time. He has to measure the blood sugar before going to bed. Other thing as well, you have to teach his family about how to deal with hypoglycemia in case it happens. I mean hypoglycemia, the bad hypoglycemia. You will provide them with glucagon kit. What's glucagon kit? Sort of glucagon injections available to the family to give it to him in case he develops bad hypoglycemia. Last thing, you will ask him, have you driven out? Do you drive? The one who's on insulin, I mean, he should not drive back home. He should not drive back home. But the one who's in insulin and he's having some episodes of hypoglycemia, he should inform DVLA. So again, number one, advise how to spot signs of hypoglycemia and how to prevent hypoglycemia in case it happens. And you should teach the family about how to spot the hypoglycemia and how to treat it. And last thing is DVLA. This is the station so far. It came first in November and it's lacking in manuscripts. So please make sure that you know how to elaborate it. Okay. So next station is almost similar to it.
So, Dr. Ahmed, we have two scenarios for hypoglycemia, right?
Yeah.
One with the episodic dizziness, and the other one with who comes to you with dizziness or drowsy, right?
No, wait. For the hypoglycemia, there are three scenarios actually. One is SIM-Man.
Three scenarios.
Yeah, one is SIM-Man.
Oh, SIM-Man.
This is number one. Number two, the counseling, which we are going to discuss right now. Tariq Ahmed, sorry, the counseling, which is a guy who's getting married tomorrow. And the third one is the one we just discussed right now. And you can also consider Tariq Ahmed is one of them. Tariq Ahmed, he just coming for review, but he had some hypoglycemic episode 1 week ago. I mean,
okay, thank you.
Just for the hypoglycemia, there are so far really it has been changed. Many scenarios for it. But now we have discussed only the treatment of hypoglycemia. Okay. Now we are going to discuss another scenario, which is the one who is coming for after hypoglycemic episode, and he is coming in the ambulance. He came in the ambulance and they treated him in the ambulance. And he lost consciousness, by the way, during the episode. But he here is admitted to the hospital, and he especially note he does not want to stay in hospital. So here your mission is to convince him to stay in hospital. You will ask him, how can I help you? Doctor, I want to go home. May I know why? This guy will keep repeating this sentence. I want to go home because my marriage party or my wedding party is tomorrow. So please do not overlook that. Congratulate him. Congratulations on that. We're very glad that you're getting married tomorrow. I wish it's a better start for your life. I just need to ask you a few questions to make sure that everything is fine. And if everything goes smooth, we can send you home. So now you can ask him, number one, why did you come here? He will tell you the whole story. He had some hypoglycemic episode 2 hours back or 1 hour back, and he started feeling dizzy. After that, he fell and he went unconscious. He had sweating and drowsiness, and he went unconscious. And they called the ambulance for him, and the ambulance brought him here. Okay? So this is the whole story. Why did he get hypoglycemic? Why? Actually, because this guy he took the insulin in the morning and he forgot to take the breakfast. He forgot again because he was rushing. He was preparing for his wedding, so he went outside to bring the stuff and he forgot to take the meal. Now take some past medical history. Very important past medical history. Please focus here in the past medical history on the medical conditions. Why? Because this guy is having diabetes. Elaborate the diabetes very carefully. How to elaborate the diabetes here? Since when it has been diagnosed? How is it managed? Do you take it regularly? Any recent change in the dose? Any extra dose or missing dose? Is your diabetes well controlled? How to say it's well controlled? Do you have any symptoms? Like what, doctor? Like do you feel thirsty? Do you go to the loo more often? Okay. Do you have any complications of diabetes? Like what, doctor? Like any eye problem? Any food problem? Do you measure your blood sugar regularly? Do you have glucometer at home? Do you follow up with your GP? Do you attend your annual review? All these questions, these 10 questions should be asked because this is counseling and this is sort of diabetic station. Do not overlook them. Do you have any other medical condition? No. Do you take any medications apart from insulin? No. Any family history of any medical condition? Yes, diabetes. Lifestyle, smoking, diet, alcohol, physical activity. Very important question as well. To ask this patient, whom do you live with? Why? Because this patient will be likely he's having dizziness. I told you if anyone is having dizziness, it's very important to ask this question, whom do you live with? He will tell you, doctor, okay, I will send them to you as well. I can send them to you right now, actually, after. Okay, Dr. Ella, again, can you write after me or you cannot write after me this time? They will be repeated to you 4 times right now. I mean, in the remaining 4 stations. I will write them to you as well. So basically, now people need from today warfarin because I'm making my notes. Warfarin plus hematuria with diabetes stations, diabetic elaboration, plus from the past days domestic violence, insomnia, and colleague, and cannula. beside other ethics station. Right? First lecture, I posted its notes. Oh, yes, you mean it is found in the first lecture, Dr. Zaid, right? Colleagues and Canal. Yeah, it is present in the first session, which means that Dr. Elvira did not read the note of the first lecture. Okay, Dr. Elvira. Ethics in general. Okay. And okay. I told you that in the ethics, I will tell you the scenario and then the counseling as well. In the medicine stations, I think there is no general approach because, you know, we spoke about it for 4 lectures. The history taking stations, they are quite similar.
Yeah, and the chronic disease is
yes.
There are 10 questions.
Yeah. For the chronic disease, we spoke about them in the first session, but I will repeat them in written notes. I'll provide the written notes to you after the course directly, in case anyone wants to check them. Okay. So in this case, actually, you will elaborate the diabetes, you will ask about family history, you will also ask about lifestyle, and in the management, you will tell him, by the way, do not forget to do some investigations to this guy. Which investigations? The most important thing is to measure the blood sugar right now and measure as well the HB1AC to see how the blood sugar is well controlled. So here in this station, you will find that the blood sugar is controlled and nothing is problematic. So you will tell him that you had hypoglycemic episode. Why did I have it, doctor? Because of the insulin that you took without taking a meal. Yes, doctor. So what are you going to do to me right now? Again, keep in the hospital. Why, doctor? I don't want to stay in hospital. This guy is having many errands to do before his wedding. Congratulations. Keep congratulating this guy till you get bored. He has some errands to do. I'm sure that I know that it can be frustrating, but we need to keep you here because otherwise you'll be having this disease for longer. What are you going to do for me? We need to give you, or we need to monitor your blood sugar and monitor your insulin dose as well. Doctor, but I need to go home. May I know why? Doctor, I'm just not comfortable here. Here it's very important to point out to him 2 things. Why you should keep him in the hospital? Because we need to monitor your glucose and your insulin. This is number 1. Number 2 as well, that if he goes home, or sometimes the brain effect of this hypoglycemic episode can last for up to 24 to 48 hours. So that's why we need to observe him at least for the 24 hours. Number 3, that he lives alone. So if he gets his dizziness while at home, he can have a fall, and this can be risky to him. So again, because we need to monitor, number 2, the brain effect, and number 3, he lives alone. He lives alone. His wedding is tomorrow evening, by the way. So you will tell him that I'm sure your health comes first. Sometimes he asks you some silly question, doctor, what about my fiancée? Doctor, I need to call my fiancée right now to tell her. Definitely, you can talk to her and I'm sure she will understand better than anything. Doctor, what if she doesn't accept? This question actually is a very awkward question. What if she doesn't accept? I don't want to tell you that you can answer a very awkward answer and tell him that she does not love you. She does not love you then. No, this is not the answer. You can tell him, I'm sure she will understand your condition and she will encourage you even to stay at hospital because this can be risky to you and you will not be able to enjoy your wedding. Okay, so now again, similar thing. After finishing, you have to advise him how to spot signs of hypoglycemia, to keep sugary things with him, and to inform the family about hypoglycemia signs and how to tackle with them as well. And it's very important to monitor the blood sugar regularly and measure it regularly, especially at night time before bedtime, at 2 a.m. in particular. And DVLA, very similar to the past station. Spot signs of hypoglycemia, teach a family about hypoglycemia and DVLA. This is, in the end, say I might expect now to be one of these. Yeah, just saying. By the way, sometimes this guy is a gay. Sometimes, okay? So if you want to attend the chat, it's fine. If you want to attend the wedding, it's fine. So this station is quite similar to the past station, but the only difference is that this guy was already diagnosed with hypoglycemic episode. But in the previous station, you are the one who diagnosed the hypoglycemia. The hypoglycemia station came first in October, late October or November. Please mind this station, okay? Because it's a little bit disappointing or it's a little bit challenging when most of us see a deteriorating or dizzy patient, they start panicking. In any station in which the patient is dizzy, always check the vitals. Dizzy, drowsy, whatever, check the vitals. What are the reasons of dizziness? Could be maybe bad fever, could be postural hypotension or any hypotension generally, could be hypoglycemia as well, could be maybe tachypnea sometimes. So if you check the vitals, you will get the clue on to approach how to approach the dizziness, and you will definitely reach the finding. Yes, meningitis, bad fever, bad fever. So here, this is the station so far. Now we have to move to the next one. What is the next one for today? Next one for today is normal diabetic review. In the diabetic review stations, they are the easiest stations that you can get in your exam. Why? Very similar approach. By the way, for those who are just asking, we are still left with diabetic retinopathy. Sorry, before moving to diabetic review, and actually it's one of diabetic review, we are now left with 2 more stations apart from this. And I can discuss the colonoscopy and the HIV tomorrow. Tomorrow we'll be left with only 3 to 4 ethics stations, with 3 to 4 counseling stations only. So I'm left with 2 stations after this one. Okay. So in the hypoglycemia, okay, reasons to admit who? Fumi, tell me reasons to admit whom? The hypoglycemic patient? Reasons to admit the patient is that we need to admit him to monitor his blood glucose for the next 24 hours. Why? Number 1, to monitor the blood glucose. Number 2, sometimes it takes up to 48 hours for the brain to recover from the hypoglycemia. So we need to keep him for the next 24 hours, at least. Number 3, because he was living alone. So he's likely, if we send him home, he can develop hypoglycemia at any point. And he can have a fall due to this disease. And it can happen to him at home as well. No one will save him. So definitely, we have to keep him here in the hospital. Okay, so last thing is that the hypoglycemia of taxi driver. In the taxi driver, Mr. Tariq Ahmed, it came to me, by the way, in my exam. This guy is very nice. And what you can do here, it is diabetic review, but in disguise. How? This patient will tell you, doctor, I'm here for my review, but I'm having some concern I want to share with you. And he will tell you a story that 1 week ago, he was driving the taxi after a party. He was in a party and he took many sugary things. I don't know, the people from Pakistan here, they know it. It's called Rasgullah. And he took it. And after it, he feels that he overtook the sugary stuff or the sweet stuff. So he overtook, so he decided to take an insulin dose, or he increased the insulin dose. So when he increased the insulin dose, after that he started feeling sweating and dizziness. Okay, he called his sister nurse. She told him that he should take something sugary right now. So he should take something sugary right now, and after that he stopped, he pulled the brake, and he started feeling better right now after taking the sugary stuff. So he told you the whole story. Right now, you could pick up from his history that he is diabetic. Now again, move to the diabetes. Elaborate the diabetes itself in the past medical history. Do you have any medical condition? Or sorry, did you have any similar episodes in the past? How was your health recently? Do you have any medical condition? Now elaborate the diabetes in details. Again, any other medical condition, family history as well, lifestyle, very important lifestyle. In any diabetic review station, you have to ask about the lifestyle. Please ask about the lifestyle in details. Now what? Move to the other part. Dr. Bina. Dr. Bina, tell me, in diabetic review, after taking the history, what should I do?
Examination.
Perfect. What if you forgot the examination? This part of your diabetic review is usually on any review in the medicine, you have to examine the patient. Which examination you are going to do here, Dr. Bina? Dr. Bina.
Yes, all the examinations, sensory and not motor, sensory and touch and all that. Temperature.
You forgot one important thing.
Pain and what else?
You think you are going only to examine neurological examination?
No, obviously not. Vitals, general physical, blood sugar.
And blood sugar is part of the examination. Okay.
And eye examination, yes. And what else?
Yes, Dr. Nigar. Thank you so much, Dr. Nigar. Applause. Applause, Dr. Nigar. You saved me from a heart attack right now. Because I have been always stressing on the BMI in case of diabetes and any cardiovascular disorder. You can find that the BMI of this guy is high a little bit. That's why actually his diabetes is not well controlled. So the BMI is high from the examination. And in the investigations, you'll find that his sugar could be high or his HbA1c is high. So now you have BMI is high and HbA1c is high, which means that the diabetes is not well controlled. Sometime from the history as well, he can give you that he goes to the loo more often, or he feels thirsty these days, or sometimes he does not take insulin. So those all things show that the diabetes is not well controlled. Now move to the disclosure. You will tell the patient will ask you, what did I have, doctor? You will tell him that you had an episode of hypoglycemia and explain it to him. Why did I have it? Because insulin and no meal. Okay. What is the other thing as well? Now you are going to give him general advice. What are you going to do for me then, doctor? At this moment, you tell him that we measured your blood sugar, or we have done some examinations and investigations to you, and all these show that your blood sugar is not controlled. So I have to give you some few advices. Number one, you will give him some advices regarding the hypoglycemia. And number two, you are going to give him some advices regarding the diabetes. Regarding the hypoglycemia, again, spot signs of hypoglycemia, teach the family about hypoglycemia, measure the blood sugar regularly, and devalue. Very important thing. The core of this station is not what all I say. The core of this station is the devalue, because this guy is a taxi driver. The devalue states that if someone is having diabetes and they are on insulin, they have to inform DVLA. And if they had any episode of hypoglycemia, they should inform DVLA as well, especially while driving. So you will tell him that you should inform DVLA. Why, doctor? Because the DVLA states that if you are on insulin and you develop any hypoglycemia, you should inform DVLA. What they are going to do, they are going to assess him, monitor his diabetes, or they are going to check on him, and if he complies with the standards of driving or not. The DVLA issue some standards of driving for diabetic patients. Are they going to take my license, doctor? Please don't worry. The aim of this is to assess you and check your compliance with the driving rules, because this is for your safety and for the other people's safety as well. Okay, so this is the DVLA. Number 2, you will give him some signs about hypoglycemia while driving. What should he do while driving? He's a driver. Number 1, if he is taking a long trip, always measure the blood sugar before the trip and every 2 hours during the trip. Number 1. Number 2, if he ever finds that the blood sugar is lower than 5, if lower than 5, take something sweet. What if it is lower than 4? If the blood sugar is lower than 4 at any point for a driver, what they should do, they should pull the brake, stop the car, okay, turn off the engine of the car, pull the brake, and after that, what they are going to do, they are going to move from the driving seat or the driver's seat and take something sugary and relax at least for 45 minutes, at least. So again, stop the car, move from the driver's seat, take something sweet. Okay, and then back to the driving again after 45 minutes. You'll advise him as well that you should not drink alcohol, especially while driving, because alcohol increases the chance of hypoglycemia. And he should always keep something sugary in his pocket. Okay. This is one portion. So the driving advice or the driving tips are the core of this session together with the DVLA. One other portion. Sometimes, as I told you, you can find that his diabetes is not well controlled. So you will tell him there are some few things that you can do and some other things that we can do for you. Like the lifestyle. The thing that you can do to yourself is, number 1, you'll advise about the diet, and usually the diet and his physical activity. The only positive things, diet and physical activity. Then the thing that we can do for you, we can monitor you regularly, especially in the review, the diabetic review, and we can review your medication or the dose of your medication, and we are going to check the control of your blood sugar, do some cholesterol and liver and kidney function tests, monitor your blood pressure, do eye and food checkup. Again, what we can do to any diabetic patient, number 1, monitoring the blood sugar, the HbA1c. Number 2, reviewing his medication from time to time. Number 3, monitoring the blood pressure and the kidney function test and the cholesterol and the liver function test. Okay. Number 5, eye checkup, regular eye checkup, and we can send it into specialist as well, eye specialist. Number 6 is the food checkup. Those are the most important things in any diabetic station or any diabetic follow-up. Keep them in your mind because we are going to use them in the next 2 stations. So for the control of diabetes, there are some things that you can do and some other things that we can do. What he can do, number 1, take the medications regularly and measure the blood pressure, measure the blood sugar regularly. Number 2, lifestyle advice, like including diet and smoking and physical activity and alcohol. These are the things that he can do. What are the things that we can do to him to follow up, monitor the drug, blood pressure and blood sugar, and blood cholesterol, kidney and liver function test, eye checkup, and food checkup. Those are the points. Next station is quite similar to it, but he did not have, it's even quite easier. In this station, simply, we are having someone who's coming for diabetic review. Again, you will elaborate the diabetes, but you will find that the diabetes is not controlled at all. What is the reason of diabetes which is not controlled, Dr. Ofudeli? Dr. Ofudeli, tell me, what are the reasons for uncontrolled diabetes in general? What could be the reasons?
Reasons could be inadequate intake of medications.
Perfect. What else?
It could also be due to some form of infections, and then inappropriate follow-up.
Okay, what else?
I think when it's not attending regular follow-up, that could be also one of the causes.
What else? Lifestyle.
Yeah, lifestyle.
Those are the most important thing in any diabetic patient, even in our real life. Most of them are not following diet chart. Most of them are not physically active. They drink alcohol, maybe they are smoking as well. Okay. So these are the reasons for uncontrolled diabetes. So please do not forget to monitor or to elaborate all the things. Dr. Maria, how are you? So, Dr. Maria, tell me,
I'm
Dr.
a little bit sleepy.
You're a little bit what?
Sleepy.
Yeah, I know it's late there. We are finishing in a few minutes. Okay, Dr. Maria, tell me, what are the examinations to do here? Quickly.
What are the examinations we do here?
Yeah.
From head to toe.
And
also we need to monitor the blood glucose regularly.
Yeah.
And we need to review the medication regularly.
Those are the examinations,
some kidney
right?
and liver function tests.
Wait.
Yeah, and the eye and food.
Wait. I just asked you about the examinations. Which examinations that we should do here?
Oh, okay, from head to toe.
Yes. What else?
What else? Some neurological examination.
What else?
I don't know. Like, I don't know.
Okay. So, Dr. Maria, this is your last chance because you just came out of the trauma of PLAB 1. Okay?
Yeah.
And okay, so the last chance for you, because tomorrow if I ask you the same question and if you stumble in it, Dr. Maria will pay a fine. No, it's not you. Dr. Mahdi will pay the fine. So
Yeah, okay, then it will be fine from my side.
So unfair, seriously.
No, this is not going to be happening. Okay.
Okay, so guys, here simply, Dr. Maria forgot to mention the BMI. Should I kill her? Yes, I should kill her. But I will give her...
Yeah. Okay, I'm so sorry. I just forgot it.
No, tell the examiner I'm so
I'm
sorry.
sleepy.
Yeah, I know.
My fault. I'm sleepy.
Okay, so I will ask you first thing in the morning tomorrow. So if you forget about it, this means that it was not your sleepiness. Okay. So here,
no problem.
Here you have you have to mention the BMI here, and you will find the BMI is quite high. And investigation similar, which you are going to disclose your diabetes is not well controlled. Why? Pick up from the history and from the examinations and from the investigations. For example, from the history you told me that you go to the loo more often these days. From the examinations, I could find that your BMI, which is your weight in relationship to your height, is high. And from the investigations, I could find that your blood sugar, the controlled blood sugar in the past 3 months is high. So here, what you can do, there's something that you can do and some other things that we can do for you. Similar approach. The last station for today is the diabetic retinopathy. This guy has been, he went to the optometrist. Okay, the optometrist, or sorry, he went to the GP. The GP, no, sorry guys, he went to the optometrist. He went to the optometrist for eye checkup. And the optometrist actually has written or has examined his eye, and he saw in the eye, actually, he saw some changes. Which changes? Some background changes in the eye, retinal background changes. What does this mean that this patient is having diabetic retinopathy? Because the test tells you that this patient is diabetic and he went to the optometrist. So you will enter and you will find the letter or the report written by the optometrist. Now you will excuse yourself from the patient and read the letter you will find that it's written it's written background choose. Now move to the patient, take history again. But here you have to start with number one, why did you go to the optometrist in the first place? He will tell you, doctor, I had some problem in my eye. Which problem? I had some blurry vision. When did it start? How did it start? Has it changed? Both eyes or one eye only? Okay, this is the only difference between this station and the previous stations. Now move to the past medical history. Again, similar thing. Elaborate the diabetes very well. You will find that this guy is not compliant with the treatment or not taking the medication regularly or whatever. Ask about the lifestyle. Do examinations. Which examinations? BMI, Dr. Maria. And
Yes, I
and
got it.
eye examination and neurological examination as well. Okay. After that, investigations, blood sugar and HB1AC. Both of them are high. So you will tell him that your diabetes is not well controlled. Or you can simply tell him, do you have any idea why did your optometrist refer you here? Why, doctor? Because he was suspecting you have a condition we call diabetic retinopathy. What is diabetic retinopathy? It is simply some retinal affection or some eye problem as a complication of your diabetes. And that's why you are having this problem in your vision. Why did I have it, doctor? Because actually diabetes can damage the small blood vessels which supply the eye, especially the retina. Do you have any idea why this happened to you? I mean the diabetic retinopathy, why it happened to you? Why, doctor? Because actually your diabetes is not well controlled. So you will tell him that you're having diabetic retinopathy. Explain it to him. And then explain the reason why does he have it. So what are you going to do for me? Again, something that you can do and some other thing that we can do. Very similar advice about smoking, diet, alcohol, and physical activity. Why I'm giving him the lifestyle advice? Because actually his BMI was on the higher side. So losing weight will reduce the chance of developing complications. What we can do for you, here again the same thing. We are going to monitor you. Monitor your blood sugar, monitor your medications, kidney function test, and blood cholesterol and blood pressure monitoring. Remember, eye checkup. Here, the eye checkup is the difference. Why? Because we told him that he's having diabetic retinopathy. That's why we are going to refer you to specialists. What will the specialist do? The specialist will do a procedure called laser photocoagulation. What is the aim of this laser photocoagulation? Laser photocoagulation, the aim of it is to seal any blood vessels. Seal any leaking blood vessels. Okay, so again, you are referring him to specialist. What will the specialist do? He will do a procedure we call laser photocoagulation. How is it done? Simply putting eye drops and then doing it. And after it, he can feel some blurry vision after it. He will do it on both eyes. So you will refer him to specialist to perform laser photocoagulation here, and it will be performed on both eyes. In case that background changes are found on both eyes. And actually, they are even going to do it on both eyes. Why? Because the chance of the affection of the other eye is high as well. Last thing, you can tell him that we are going to do food checkup. So, this station changes every now and then. Sometimes they bring for you the guy with diabetic retinopathy. Some other times they have sensory loss, or he is having sensory loss below the knee. So here your concern in the sensory loss, that the foot checkup. The foot checkup, and you will teach him that he should not wear tight shoes. He should carefully inspect his foot from time to time and his fingers. We are finishing right now, Dr. Mahdi. And you need to check his foot from time to time, not wear tight shoes. Okay? Okay, Dr. Mahdi, have a safe flight. Have a safe flight. Bye-bye. So here, these findings can change from time to time. Sometimes,
Thanks.
you're welcome, Dr. Man. So sometimes it's because of, sensory loss below the knee. Some other times due to retinal changes. Many reasons for it. So it can change. So you pick up the finding and address it in the management accordingly. So this is the station so far, or those are the diabetic stations so far. We are left with the statin. Okay. We are left with the statin together with two stations, the colonoscopy and the HIV. We are discussing them tomorrow, the first thing, together with 2 or 3 remaining ethics counseling stations, and we will go to the, mostly we'll go to the surgery stations, surgery counseling. Okay, so we are done for today. Guys, some people have been suggesting that we start at 3 p.m. UK time. What do you think, guys?
Please no. No.
Actually, tomorrow it's not possible because tomorrow I will be, I may even be 15 minutes late than 4 p.m. So we may start at 4:15 tomorrow, but it's not possible that I start at 3 tomorrow. I'm sorry, this is the exception. But after that, can we start at 4? What do you think? Sorry, at the 3, what do you think?
Let's vote.
No, I mean other people, what do you think?
It's a yes from my side.
Because I know that you need to sleep late. You need to sleep early. I know it.
Yes, from my side also. As
Yes,
it is 1
from
p.m.
my
in
side.
Okay, so now most of the people are not comfortable with
Dr. Ahmed,
3.
3 is fine. 3 is fine.
For you, it's fine?
Yeah.
Oh, yes. Dr. Maria, we are just left with 6 days. Bear with me, Dr. Maria. Bear with me. I know it's late. Believe me, I stay till late night. I used to stay till late night for my PLAB 1 and PLAB 2. Just 6 days, Dr. Maria. Believe me, those 6 days will make a big difference in your career, Dr. Maria. Don't worry about that. I know that you need to sleep. Okay, so I think we will go for 4 p.m. because some other people are having some family commitments. Okay, guys. So thank you all for today. I know it's getting more boring, but you will learn too much, inshallah, and you will apply it in your exam, inshallah. So see you and sleep well. See you tomorrow, inshallah.